about the end of 2016. And this was a point where I was at a particularly low ebb because I hadn't worked for 2 years, and I convinced myself that I didn't really have anything to give back. So this is one of the reasons I'd really retreated. But here's the thing, the outrage that I felt at how our city was managing the replacement of trees, so felling perfectly healthy trees in order to replace them with younger ones, really cut through all my reservations about my ability to be involved and, you know, actually be make any kind of meaningful change. Because well, the thing that set me off in particular was that I'm a strong believer in community consultation, and a whole section of street trees on a street just 2 or 3 minutes around the corner from me was felled, and the first I knew about it was after it had happened, and I was beside myself. I was so angry and so upset, and so this had this profound motivating effect that actually cut through all the walls that I'd built up around myself, or at least started to break them down. And there's something about being in the position that I was, where I felt like I had nothing to owe anybody, you know, I had no job to worry about, I was a free agent, and that's profoundly liberating. And at first, you know, as many people do, you start off by being a keyboard warrior. You know, I use that expression advisedly, but I felt that that was where I could be really involved. I could draw on my academic experience, my landscape architect training, to try and be the voice of reason, because it was an emotional situation. Everything was very fraught. And the idea was to just try and make sure that, you know, the worst accusations on both sides were addressed, because lots of falsehoods were flying around at times. And also just to constantly refer back to best practice and national policy guidelines, and just be the critical friend that the council needed. So this went on for a little while, and then in February 2017 I found myself in a very interesting moment in time, because I turned up on Chipping House Road in Neveredge, where the police were leading a very heavy-handed operation to remove various tree defenders from that street. And it got heated, and it was a very surreal experience, because there I was facing down the police inspector and saying, you know, various things about the right to walk down a pavement, and why was it that we were being asked to move consistently further and further away from the tree so that we couldn't defend it, and talked about the right to peaceful protest, all while I was suffering from an MS relapse that was quite badly affecting my right hand side. So it was this weird paradoxical situation where I was feeling physically awful, but I was actually involved and, you know, awake to something new. So in that week, I was there for 3 out of the 5 days, because every time I spent the day there, I was so exhausted and emotionally overwhelmed that I'd then take a day off, and then I couldn't help but go back. So I was there for 3 out of 5 days that week. And it was chaotic, but it was kind of instrumental, and new alliances were formed in that particular period. For many months after that, there was a really good peaceful strategy to stand directly underneath trees and just refuse to move. And this actually worked very well for me, because luckily I speak the language of trees, so I could be quite, you know, friendly with the arbs and talking about them, what they do, and kind of appeal to their better natures, those that had them. So, you know, it was a relatively unconfrontational situation, and, you know, I helped diffuse that. And this was good, because it just meant all I had to do was stand there. And this meant that I did save dozens of trees, most of which are still standing, I'm pleased to say. And what this showed me is that I was just one person under a massive tree with a whole group of, you know, because they were all men, all the arborists I came across, who were standing around me in a ring, and I wasn't moving. I was just stood there going, yeah, this is me, this is what I'm doing, and I'm not going anywhere. So I'd gone from feeling quite small and insignificant to actually quite powerful in a quite short space of time. The important thing is, I knew that I was making a positive difference. People were telling me that my efforts were appreciated. You know, I built new alliances with people in parts of Sheffield that I hadn't even visited before. And importantly, my horizons were broadened while I was doing this. So the situation did become more serious ultimately, because felling tactics changed, and that meant that if I was to enter what was described as a work zone around a tree, the chances are, even if I had been able to get over one of the Harris fences, which are big metal fences that are tied together, If I'd managed to get over it, which I might have been able to do on a good day, then I would have faced the security on the other side. And the idea of being roughly handled by security wasn't really for me, unfortunately. And if I'd even got into the tree, I would have had to stay put for hours. And if you've got MS and a dodgy bladder, that's just not even an option. So other considerations at this time as well was that if I did get arrested, I feared for my health if I was locked up in a police cell for hours on end. They're not comfortable, they're not particularly warm. And yeah, the ultimate threat was I feared losing my home because people were being taken to court and there was a threat of seizing their assets. And my only asset is my home, and I couldn't lose that. So this meant that I stepped back from that sort of more direct role and started helping people by being a scout effectively and just watching for activity. So it was, one of my roles was to observe various vehicles as they were coming and going, seeing what kind of felling equipment they might have them on them, whether they were bringing barriers, all that kind of stuff. And then we'd get on the jungle telegraph, WhatsApp and various other messenger groups to warn people what was coming. And on occasion, I just simply put myself in the road and refused to let them pass. And sometimes that worked. Other times they did try and run me over. So it had mixed results. But ultimately, I couldn't even do this for a long period of time because when it's very cold, it's very difficult to stand still in my experience. So I can walk about in the cold, no problem. But if I stand still, I seize up. And I got some really bad spasticity in my legs. So that was the end of that. So I once again went back to campaigning online. And I really want to make a point about this because the people who, you know, effectively are in the limelight, get all the attention. They're the ones who, you know, put themselves in harm's way, and they, for better or for worse, they get a lot of attention. And this kind of ignores the massive support network of invisible people that work behind the scenes. And I think you can commit your time at all different levels in activism, and to be able to just, you know, do it at your own pace from the safety of your own home, from the comfort of your nice comfy chair with a computer in front of you, should not be underestimated. So that's why I use the word keyboard warrior advisedly. I actually have a lot of respect for people who take the time to talk to other people and educate them about, you know, what is right and ways they can help their community. So because I was always careful to base my criticisms in fact, it's actually turned out to be a really good thing for me, because I now do work with the council. I have worked very closely with the Parks and Countryside Department, particularly the Woodlands team, to deliver walks around the city, tree walks. And this is partly through the Sheffield Woodland Connections Tree Charter branch that I set up. And that continues to this day. But I've also recently taken on a position for doing advocacy for urban agriculture. None of these experiences would have come about if I hadn't have been actively involved in the campaign, because people know who I am, they know my face, and sometimes that's a good thing, sometimes it's not such a good thing. But what I've managed to build is a reputation of being somebody who is an activist, but also a relatively reasonable person, somebody that you can work with, somebody that you can talk with. Most importantly, it's been the professional and personal relationships that I've built up caring for Sheffield's natural assets, because that's what's allowed me to launch the career that I have now. And I couldn't have imagined that when I started, you know, committing my time to the campaign at the beginning of 2017. And it's really powerful how much it's brought me out of my social isolation and made me feel like I can actually contribute to my community. I can't really stress just how transformative it has been. It's been a powerful force for good in my life, not without its complications, but mostly very good. And I found that carrying on, being really active and being honest about my health needs as I talk to people, and being, you know, allowing people to see my vulnerabilities has actually been a very good thing. And some of the projects that I work with volunteers, and I create safe spaces so people can talk about their mental health and things, that the other situations that concern them in their everyday life. And being able to share your private story and show that you're, you know, you're just like everybody else, it helps build community. And really importantly, it helps be a catalyst for important conversations to take place.
Great. Thanks very much, Fran. Thanks for an excellent start to the day. Thank you for the presentation. If you could now turn your video and microphone off, that would be much appreciated. So our next speaker for this section is Dr. Brian Fisher, MBE, and Brian is a GP and chair of the Socialist Health Association. and is going to be talking about the impact of community development. Brian, I'm going to hand over to you if you'd like to turn on your camera when you're ready, please. That would be great.
You're not allowing me to turn on my camera, it looks like. Okay. Oh.
Perfect.
Great. Thank you very much for having me here. That was a fantastic start, Fran. Thank you so much for speaking like that. It actually speaks very, very much to the topic that I want to talk about. I do need to share my screen because I'm going to be showing some slides, and mine is a much more theoretical discussion than yours, but you've highlighted really some of the key issues there, Fran, that I'll be talking about. Screen sharing is disabled, okay. I'm afraid.
Simon, you might need to make Brian a co-host. Yeah. Should work now, Brian.
Yeah, okay. Thank you. Can people see that?
Yeah, perfect.
Okay, great. That's brilliant. Thank you so much. So yes, I'm Brian Fisher. I'm a semi-retired GP in South East London. I'm chair of the Socialist Health Association, proud to be so. And I've been interested in community development and health for a long time. And what I'd like to do is to give you a sort of galloping tour of the concept and the evidence for why community and health is so important. So the important messages to get across are that there is a lot of evidence for this, that contact with other people that's meaningful and constructive helps build confidence and helps people to see themselves as being able to do things for themselves and for others. And that enables people to take much more control over the circumstances of their lives and environment. And I think Fran was really talking to some degree very powerfully about that experience. So if we look at those ideas, particularly of contact and confidence, first of all, and I'm going to try and show what the evidence base for this is and how important it is for people's health. So what we know is that community development, community strengthening, bringing people together and building social networks, which means that the friends, family, pubs, clubs, the links we have with other people, the stronger and deeper those are, that builds resilience in communities. So it, for instance, builds resilience to economic stress, to COVID, it builds better mental health. And linked with that is the concept of enhanced control, so that communities can then negotiate, for instance, with the statutory sector, just as Fran has done. And it gives people the ability to look after themselves better. And there is some evidence that it helps to tackle health inequalities. So those are the sort of ideas that are behind what I'm going to be talking about. And Public Health England is very clear about this. Being connected with other people improves your mental and physical health. And we all know about loneliness as a sort of one element to that. But this is now really quite well established in public health terms. Here is an example. You live longer after a heart attack if you have more emotional support. A very concrete example of how social networks can improve our health. And when you look at many studies together, so this is a meta-analysis of many other studies, and it controls for sex, age, cause of death, there is a hugely increased likelihood of survival for people with stronger social relationships. So this is equivalent to stopping smoking. So these social networks, the way we live in our communities and how we relate to other people, has an enormous impact on our health. We know that there is not just our health, but crime and delinquency are lower in places with stronger social networks, that it's easier to find jobs because there are contacts between people who can share ideas and share information. And one example of a community development approach showed that after a couple of years, people's perception of the area being a good place to live was substantially increased. People looked after each other better, and people felt much more in control over things in their area. So these are the kinds of things that change when you build communities up. And again, Public Health England is very clear that that this kind of community development approach can reduce health inequalities, give people a stronger say, and engage those most at risk of poor health. So if we look now particularly at the concept of control rather than the concept of contact, Marmot, who is the sort of guru about health inequalities, is very clear that our society needs to enable all children, young people and adults to maximize their capabilities and have control over their lives. And at the same time, we must create and develop healthy and sustainable places and communities. And again, Fran gave us a fantastic example of how that can take place. And looking at it in a slightly bigger picture, this is evidence from Wigan, which many of you may know has changed the way it operates so that it thinks much more about what communities want. It listens to communities. It works in a much more community development asset-based way. And the result of this over some years is very substantial. So when you look at Wigan's outcomes in relation to, well, compared to similar places, it's really quite stunning. So life expectancy is higher, deaths from cancer have decreased, alcohol-related hospital admissions, suicide rate. They're very substantial changes, which the council and the public health department there have put down to this new kind of way of working. And the key message is that our health improves if communities can take back control. So it's an issue, a political issue of participatory democracy, that it makes a difference to the way we feel, the way we think, and our health. So it's a link between a bigger picture and the way each individual feels and operates. And financially speaking, it's hugely beneficial as well. So community development, there is a social return on investment of about 1 in 3. So every pound you spend, you get about three pounds back. There are some projects where that ratio appears to be much greater, but on average, we're talking about a 1 in 3 investment. So overall, when I use the word community development, I'll be explaining that in a sec. What you can do at the same time is that statutory services become more responsive, as Fran has discovered. It promotes health protection and community resilience, helps tackle health inequalities. It changes people's individual behavior. Nice guidance has made that clear. And it's a good investment. It's a pretty powerful intervention that we think all places ought to use. So in the NHS, we think primary care networks, we think local authorities ought to reinvest in community development. They used to, but they haven't done for a long time. And this is what we mean by community development. It's a model. There are many different kinds of community development. This is a model that was developed by Hazel Stuteley, who lives and works in Cornwall. She calls it a resident-led partnership. And the idea is that people in a place, in a primary care network, on an estate, they take the lead. And this is almost certainly necessary to have a trained community development worker to start this process off, but not necessarily to continue it. That the residents decide what the issues are that matter to their area. And they then draw in the statutory sector to them and work with them on sorting out the issues that matter to that area. So it's not about...
Sorry, Brian, just to...
Yeah, I'm nearly finished. It's not a matter of public health saying, you know, we know you're fat and you smoke too much, let's talk about it together. This is about the residents defining things for themselves and making change with the statutory sector. These are the kind of changes that have happened. This is Play Park, which when discussed with the council transformed into this. And there are youth activities in Cornwall which led to a dramatic drop in crime, which was seen to be the result of this kind of activity by the police. And of course, there is a political dimension to this, that we know that when you shrink the state at the same time as causing austerity, you kill people. And the evidence for that is now very strong. There are tens of thousands of excess deaths in this country over the last 2 years because of austerity, quite apart from COVID, which is a whole other disaster to talk about. So we think community development is a well-established and well-evidenced intervention that everywhere should look at, particularly Sheffield. So thank you very much for listening.
Great, thank you very much, Brian. Sorry for cutting you a bit short there. Thank you very much. If you could turn your video and microphone back off, that'd be much appreciated. Thank you. So next up, we're going to hear from Kelly Hick and Glyn Butcher, who are from PFG Doncaster, an amazing peer support organisation based over at Intake in Doncaster. I'm going to hand over to you now. Glyn, if you'd like to turn your video and microphone on, that would be, there you go, yeah.
Hello, everyone.
Hi, Glyn, go for it.
Hello, everyone. I'm not sure whether Kelly's here. I think you might have just got me. I'm here today to talk about peer support, what is peer support and what our organisation does. I just want to thank you, Brian and Fran, for the amazing presentations, because it just brings it on to what I'm going to be talking about. So peer support, what is it? It's people helping people. It's the power of community. It's about bringing people back from the edge of community back into the centre. It's about love, care, compassion. It's about kindness. It's about people giving people choices and about giving people opportunities to succeed. Being part of my community, being part of PFG did something for me that no other services have ever done, ever. I've been in mental health services since I was 14 years old. I've been through drug services. I've been through the criminal justice system. I'm also a carer for 2 people with mental health problems. I always felt like an outsider. I always felt like I didn't belong anywhere. Mental health services, I felt like a number. I didn't think like a fit in. But when I become part of my community, I changed. My community changed because of me, and I changed because of my community. And peer support is magic, is magical, because what happens, it allows you to be the person that you've always wanted to be. It brings you back in, like I said, back into the centre, and it empowers you. Peer support empowers people. It gives people a voice. It gives people opportunities to speak out about the things that really matter to them. It gives you opportunities to work with other organisations. It gives other opportunities to work with the council and other strategy services. Peer support is about looking at people as people, not numbers, not objects. Peer support is about celebrating people's skills and abilities. Peer support is about looking at people and seeing value. Peer support is about seeing your community as an asset and everybody in your community as an asset and working with them assets. We work on a strengths-based model. We don't ask people what they can't do. We ask people what they can do. We don't get involved in diagnoses and treatments and things like that, which stifles conversation. It's always about hope. It's always about giving people hope, care and kindness, and giving people a voice. And it's about people choosing which part they want to play within peer support. Peer support is about giving and receiving support. So I have personality disorder, I've got autism, I've got sleep apnea, I've got diabetes, I've got all other roster illnesses. I couldn't read and write while I was 36. I was in and out of care, in and out of hospital, gone through sexual abuse. So when actually I'm in services, because I've been in services for over 30 years, I was more a problem being in services than actually being part of my community. And one thing that community did for me, I didn't want to be the person that I was in services. I wanted to be part of my community. I didn't want to go crazy. I didn't want to smash things up. I didn't want to take drugs. I didn't want to cause antisocial behavior, because I felt valued by my community. So I started valuing my community. It's a two-way thing. And the people focus group, PFG in Doncaster, allowed me to do that. I live in Rotherham, but actually I was born in Doncaster. All my heritage is in Doncaster. My family's in Doncaster. And actually I work in Doncaster. But once I was part of my community, that allowed me to see me as me and not a number, and not living some sort of dream world. That being in 30 years of mental health services made me institutionalized. I was mentally institutionalized, even though I'd left mental health services. But what community showed me was care, compassion. It gave me opportunities to sit on different meetings, do presentations like today. It enabled me to have a voice and to hear my voice speak. Then I realized I've got something to say. I'm an activist. I never knew I were an activist, but I am. I speak out for the voices that can't be heard, like I was sitting in that day centre for over 30 years, who were never encouraged to say anything. In fact, you were made to sit in groups of 8, and if you weren't involved, then you were shut out because they needed 8 people for a group. What I would say to your leaders in Sheffield about peer support and about communities is, how can you get what can you stop doing in Sheffield and get out of the way and let the community do it for themselves? What can you do to get out of the way and stop doing in your statutory services and in your councils and then over your institutions, and just get out of the way and let communities do it for themselves? That's what peer support is. It's the community taking ownership. It's the people in the community running services. In Doncaster, we have the only peer-led crisis run service in the country. Peers run the crisis service in Doncaster, not the hospitals and the NHS. The peers do, where we manage mental health services in Doncaster with support from RDASH, from Rotherham, Doncaster and South Humberside Trust, but the peers run it, because people with lived experience can help people with lived experience far greater than anybody that's read it from a textbook. So it's about bringing them skills. So we have something called support buddies, where not everybody can write, so somebody will write them a letter, but they're good at computer skills, so they'll do stuff, they'll bend their computer. And somebody else might be good at painting, but no good at computer, so they'll paint their house for them. So we share our time, we share that space, we share our skills, we share our love. We are one family. People see us more than the actual family, because when you've got mental health problems and you're isolated and lonely and you don't feel part of anything, that PFG actually becomes that your family. And for whatever reason, my family couldn't be a family, so I had to go and create my own. And that's what I learned. I learned to take responsibility for my own actions. I learned to believe. I started to believe that I have got a future. My life is worth living. I have suicidal thoughts every day. It doesn't mean I'm suicidal. It's part of my suicidal thoughts. Since I've been at PFG over the last 6 years, I've never tried to commit suicide once. I've been on drugs. or alcohol. I've not relapsed on drugs and alcohol since I've been part of my community. Why? Why? Because I feel valued in the community. Just like the doctor was saying, Dr. Brian, as he was saying, once you're part of your community and you see people and people say hello to you when you walk in Dark Street, you don't want to cause antisocial behavior. You don't want to cause a problem. You want to be part of that community. You want to be valued in your community. So the question is, how do we get people to feel valued in Sheffield? How do we get people to want to be part of peer support? How do we get people to want to be part of their community? And I can tell you now, the number one thing that the Citizen Network did with me, with Simon Duffy and yourselves, was show me kindness. Kindness, love, care, compassion. They allowed me to tell my story. Everyone has a story. Peer support is about hearing people's stories, and we need to hear your stories. Peer support is about seeing people as human beings, not as objects. People with feelings, people with emotions, people with dreams, people with aspirations. Yeah, we all don't have the same aspirations and the same dreams, but they're our dreams, and we're entitled to them. But how do we make the change? How do we connect people together? Well, you connect people together by getting people interested in the same things. So we have a peer support writing group.
Sorry, Glenn, 1 minute. I'm just...
Yeah, sorry. We have a peer support writing group. We have something called 7 o'clock Zoom meetings. Obviously, for COVID, people can't meet, so people are connecting through Zoom and WhatsApp. But thank you again for letting me speak and being part of this day. And anything else I can help with, I'm there. Thank you.
Great, thank you so much, Glenn, especially for sharing so much from personal experiences. That's much appreciated. Thank you very much for your talk. Apologies again for cutting you slightly short. If you could turn off your video and your microphone, that would be much appreciated. So next up, I'm very happy to be introducing Mr. Nick Sinclair, who runs the local area coordination network of councils across England and Wales. Handing over to you, Nick.
Thanks, Joe, and thanks, Glyn. How do I follow that? I'm not sure I can, to be honest, but hopefully what I can share with you are some ideas that might help build on what Glyn shared there, and Brian and Fran, and that we can kind of explore this a little bit through the frame of local area coordination. It really is a privilege to be with you here today as part of this excellent event, and I do appreciate the opportunity to speak with you all today. So I've been asked to focus on local area coordination's role within prevention. I think there certainly are other dimensions to it, namely how it supports people who are already accessing services to reduce a need for services in their lives, but I'm going to focus on the preventative aspect here. So local area coordination is an approach that emerged in Western Australia back in the 1980s, but it's been in England and Wales for the last 10 years or so. And it's currently been led within 10 council areas in England and Wales, and it's been rolled out across 100 or so communities. So local area coordination is an asset-based approach, but so focused on, like what Glyn was saying, on strengths and what's strong. But we're often asked, what is the problem that local area coordination seeks to solve? And I think reflecting on that, there's probably 3 interconnected issues that the councils who are driving this forward are trying to work on strategically. I just wanted to share here. Firstly, I think many people in our society are still not able to achieve their vision of a good life for whatever reason. And this, as we know, and from what we've heard there, is often due to some form of exclusion. For instance, exclusion from family, from community, from information. But when we're thinking about prevention, also exclusion from services, through eligibility, through thresholds, through funding, that sort of thing. And secondly, communities often evolve and develop without the involvement and contribution of those people who are facing exclusion, because they are on the fringes of that community and because the fact they are excluded. And this is a loss, a huge loss, and it increases the likelihood for personal crisis as people remain disconnected and isolated, unable to share their gifts and make their contribution. And finally, I think our statutory services are designed to be reactive to crisis through specialist responses, siloed specialist responses and interventions, and they're not necessarily designed to think about the whole person and to work in a way that's preventative, to build capacity at individual and community level. So those are the kind of challenges that we find people are exploring when they get in touch with us about local area coordination. And when we dig a little bit deeper into all of this, we often find that I think there's very few sustainable structures in our communities these days, whether they be democratic or otherwise, that help people to be citizens, to think, to decide, and to act together with a clarity of voice. And this lack of voice, or perhaps an ability or lack of interest in listening to it, means that sometimes policymakers and system leaders are reliant on quite headline deficit data and overview kind of insights about areas when planning and making decisions that affect the lives of the people and citizens. And this often leads to a bias for cheaper, shorter term fixes that might fit the prevailing demand reduction narrative, rather than ones that are longer term, relational, preventative, and driven by values and principles, and that are led with and by citizens. So I think the question those adopting local area coordination are often grappling with is, do we tinker with this? Do we try and fix it around the edges? Or do we try and do something that fundamentally is about reforming that, doing something completely different? And increasingly, the areas that we're working with and where the approach has been recognized, it's been seen as something that can help bring about that genuine reform to the way that social care evolves locally. So how does it work? So very briefly, to give you an overview. So we, the Local Area Coordination Network, work with councils and local communities to co-design a version of local area coordination based on various design features, core design features and principles that have evolved from the evidence over the past 30 years. Local community members are eventually involved in recruiting one local area coordinator for their local community, typically a population of around 8,000 to 10,000 or so people. Those coordinators are then employed by the council, but are based in communities to be present and accessible, to take introductions to anyone who may need help in order to live their good life. And those introductions can come from anywhere. So from local people, from community groups, from services alike. Coordinators take their time to listen, to build meaningful and equal relationships with people, and trying to find out what the bigger picture of someone's vision for a good life is. So not just focusing on one part of it, but looking at the whole thing. And there's no limit to this in terms of time, and there's no limit to it in terms of criteria. And there's no referral process either. It's about a relational thing. They develop shared agreements together as to who's going to do what. And there's often a big focus on what local support and connections are available in the community to help people get to where they want to be, with services and funded supports as a backup. So not the first protocol, but a backup. And then the learning from all of this and the insights that are coming back from people, from citizens, from communities, that's channeled back to system leaders who can then make positive reforms based on real-time insights and information and reality of things, and not just old, out-of-date information. So what impact do we see this having? Well, typically it's multiple outcomes in all sorts of different levels. So for people and families, they have a local, practical, accessible source of support there to achieve their good life, and they don't have to be signposted out of their community in order to get there, and crisis is prevented. For communities, they have a locally based, skilled local area coordinator who's present to connect with and introduce their friends and neighbours as concerns, queries, or ideas for doing something different begin to arise. And this helps build bridges and trust again between communities and wider service institutions and structures. And for service systems and professionals, they have a named person who's physically present in community to make introductions with, regardless of service eligibility. So, and this capacity this helps to build, and the crisis it helps to prevent, leads to costs being reduced and savings being created and all that sort of stuff. But it provides insights for better commissioning. I think it promotes culture change across health and social care. It enhances co-production, power sharing, and a platform for better collaboration. So those are the sorts of things that local area coordination can really help stimulate. And I just want to conclude with a short story that I think highlights the preventative aspect of this really well. This is about someone called Ella. It's a true story. Names have been changed and permissions have been sought for giving this and sharing this. Ella was attending college, but her employment advisor was concerned that she had no income. So together they reached out to Tammy, Ella's local area coordinator, to see if she could advise as to how Ella could access free food. Ella and Tammy met soon after in the community where she opened up where Ella opened up to Tammy. She had been denied the benefits she was seeking some 8 months before, and she had no income, no family support, no network of friends around her, and she was facing eviction and had no access to food other than through soup kitchens in the city centre that she was struggling to access due to the cost of transport. Now, Ella's physical and mental health were deteriorating, and she told Tammy that she felt very isolated. And when they looked into the support she was getting, she was receiving quite intermittent support through a social housing landlord, an employment advice service, and a local charity supporting people facing homelessness. So Tammy was able to help Ella join the dots between these services, put her at the center of it so she could get the full picture of what was on offer. And this included Tammy helping a lot with some practical stuff, for example, picking up food parcels for Ella, attending meetings with the landlord and the welfare rights team. And eventually, throughout that time, Ella managed to secure her tenancy until the pending tribunal, where she won her appeal and her benefits were backdated and she paid off her arrears. She was able to focus on her health again. Now, throughout that time, Ella and Tammy were getting to know each other. Tammy had also been helping Ella to meet local people in the community, to build links with local places and things that were going on. So she's met people in the community who are now offering a natural emotional support through friendship rather than through services. And Ellen's now giving back to the local community, sharing her gifts through volunteering, and is now continuing with college and seeking work. She feels more optimistic, mental health and physical health have improved. And she isn't now closed to Tammy. That's not how local area coordination works. She continues to be a presence, walking alongside Ella as and when needed. And Ella knows where to find her because Tammy is present in the local community. She's the local area coordinator. So that story of prevention really highlights, I think, the logic of the approach of being local, connected with services, but also separate, the practical input that's genuinely compassionate and centered on the person. They're not being limited by eligibility criteria or time, knowing where hyperlocal potential natural support exists in communities and making those connections, seeing the big picture and not just focusing on one part of it, and being present and accessible if needed in the future without closing people down so they have to get into crisis again in order to re-access services, for instance. And I just want to conclude in these last few seconds by saying that I think the great value in local area coordination is due to the fact that it isn't solely a community-led thing and therefore limited to the goodwill and the extent of neighbourly support and community infrastructure that exists. And it also isn't solely a service-led thing either, which is limited by eligibility criteria and thresholds. But it's something that sort of lives in this grey space between the two. And when designed right, I think can make a huge difference in building the capacity of both worlds. And I believe at this moment in our history, what we need are responses that bring the worlds of individual citizens, families, communities, and statutory services together in a much more equitable way that plays to everyone's strengths, respecting the natural authority of people, the power of communities, and the value of accessible specialist services when needed. And I believe that the local area coordination approach is well placed to support this. So thank you very much for listening.
Great, thank you, Nick, so much for your talk on there. Thank you very much. Going to move on to our next speaker, who's an international speaker, actually. Very happy to have Brendan Martin with us, who's going to be telling us a little bit about the Dutch social enterprise, Bertog, and self-managing teams. So just going to hand over to you now, Brendan.
Thank you. I'm in London, as a matter of fact, but that's international enough. Thank you very much, Joe, and thank you to everybody for having me, and particularly to be part of this panel of very inspiring speakers so far. You asked me to provide a single slide, which I did. Will you show that or will I? Okay, thanks very much. So I've been asked to talk about self-management, and I'm going to start by saying what I mean by that. And what I mean by it is that it's about enabling and supporting people to be the very best they can be. And that's the opposite of leaving them to manage by themselves if they need support. It's also the opposite of doing things for people that they can do for themselves, or telling them what to do and how to do it. As Joe says, I work with Bertog, which is the Dutch for neighbourhood care. We base our work on some simple assumptions about the human condition, which we believe are universal, and which we think are that we all want to live autonomous, meaningful, and purposeful lives, and to have warm social interactions with others in our community. And that applies whether you need a few weeks support to recover from illness or injury, or continuous support because of an ongoing difficulty or disability, or indeed if your life is approaching its end. And Björtsog, which started as one team of 4 nurses about 15 years ago actually now, has grown to around 950 teams, all self-managed, providing both personal and clinical care to people who need it in their homes. Our self-management model begins with our onion model, which you can see on the graphic. It starts at the center with the person needing support, and the professional's first responsibility is to build a relationship with her or him, to learn all about what she wants, what she can do for herself, or could do for herself with some help, and what she needs the professional to do. That involves thinking about how the people in the second layer of the onion could be involved: family, neighbors, friends, the wider community. That's why one of the key roles of our teams is to know what's going on in the community, to be part of the community, to see where the strengths are and build on them, and if necessary, to contribute to strengthening what needs to be strengthened. But crucially, to support the self-management of that community, as well as the individual, not to replace or undermine its autonomy. So for us, the professionals are not at the center, but in that third layer, supporting the self-management of both individuals and their communities. And a key part of that role of our neighbourhood teams is to help the people they're supporting to navigate and engage with the formal system of care and support, therapists, GPs, social workers, what have you, which is what we see as the fourth and most outlying layer of the onion. Now, all these layers have their roles, and we've heard about them from other speakers this morning, but they're not the same roles. And the relationships between the people concerned are crucial to success. Now, as a professional, whether you're a nurse or any other kind of professional in the care and support environment, you can't build relationships like that or work in that asset-based way unless you have the freedom to do so. In fact, the self-management of individuals needing support and of their communities requires the professionals doing that work also to be self-managed. But again, self-management in this context doesn't mean isolation or lack of support. Again, it actually means the opposite of that. Our professionals take personal responsibility for their work, but they do so in self-managed teams that provide peer support and challenge to each other. Our teams are non-hierarchical, although there are different layers of qualification and experience in them. That's reflected in what they're competent to do, but not in the level of their authority in team decisions. And although some of our professionals are specialists, they work as generalists because the people they support need holistic care, not a long line of disconnected people each doing a discrete task, but a small group who can do all that's needed when it's needed. So for example, when our teams of nurses and nurse assistants and care workers need to call upon, say, a specialist physiotherapist or occupational therapist, what they will do is build a sort of virtual team for that purpose, which lasts for as long as it's needed. So this is fundamentally about creating a trust-based environment in which professionals are enabled and supported to work in accordance with their professional ethics and craft, but with the person needing support and their communities around them. For that to work, there needs to be not only freedom to make the relationships needed and to do what's needed when it's needed. Equally important is acceptance and exercise in a disciplined way of responsibility about what you do and how you do it, and clarity about the boundaries of professional authority, both in relation to the people they support and to the organization through which they provide that support. That's why our teams work within a clear framework of a few ground rules, which are in 3 broad categories: to provide great care and support, to enjoy and contribute to an enjoyable working environment, and to do both those things in a way that enables sustainability, financial and other forms of sustainability. Our teams need support from their organisation, and they get it. They get support from coaches who don't manage them, who don't tell them what to do or solve their problems for them, but facilitate them to solve problems for themselves when needed and only when needed. And they also benefit from the support of agile, responsive back office, whose role is not to command and control, as it is in the hierarchical public service organizations that we're used to, but to support and serve the frontline professionals, just as those professionals in turn are there to support and to serve the people that they support. So if you like, there's a continuity of logic here from the core relationship between the person needing support and the professional, to the relationship between the professionals and their organizations, not command and control, but support and serve in mutually responsible relationships. So to go back to where I started, self-management for us means enabling and supporting people to be the best they can be, to live the purposeful, meaningful lives in an autonomous way as they wish. It means supporting and enabling professionals to work in accordance with their ethics and their craft, and for all concerned to work with an ethical approach. It means authority in decisions and actions where it is needed, and taking personal responsibility within an environment of mutual support. And for us, all of that is and needs to be underpinned with by shared and equal humanity and with love. Thank you very much.
Thank you very much, Brendan. That was really fascinating. Thank you for your talk. Just like to thank all of our speakers in our sort of first section of today. So thank you very much, Fran. Thank you, Brian, Glyn Butcher, Nick Sinclair, and of course, Brendan Martin again then. I'd just like to acknowledge as well the great comments and questions that are coming through in the chat. Please feel free, only of the panelists, if they want to sort of weigh in and answer any of those questions, please do have a look. Also, maybe a quick apologies. There seem to be a few trolling comments right at the beginning of that conference. So I'm sure no one needs a reminder that, you know, it's important to treat people with respect and kindness, even on the internet. We are going to put a quick poll up now, which is, you know, one of the benefits of running these live events on Zoom is you get this really quick way of canvassing the opinions in the room. So we're just going to launch this poll now, and we'll leave it running for a few minutes, and then we'll start again with our next section very shortly. a resounding win there for the 92% of respondents to that poll who believe that we need to create a system where neighbourhoods play an active role in shaping social care. So thank you very much for filling in that poll. We'll be running those throughout the day as a really quick way of capturing some information and feedback from everyone on the webinar as well. So thank you very much for filling that in. We're going to move on to our session 2 now. So I'm very pleased to be able to introduce our first speaker, Melissa Simmons, who is Black and autistic and has 2 autistic children, and she'll be talking about respecting difference for real. So I'm just going to hand over to you now, Melissa, if you'd like to turn your video.
Can you see me?
Yes, perfect.
Yeah. Am I able to share the screen as well? Is that
Yeah,
not possible?
yeah, you can. Simon, I think you might need to make Melissa a co-host to do that. Perfect. You should be able to do that now, Melissa. Yeah.
Thank you. Right, let me get into this. Hi everybody, and welcome to my session. My name's Melissa Simmons, and I also go by the name of my organisation, which is Miss Talk. And I just wanted to talk to you about respecting differences. A hashtag that's really important to me at the minute, and I try to use in everything I do, is Black Autistic Lives Matter, because I think we don't understand just how marginalised we are as a community. So as Miss Tor, I started Miss Tor about 3-4 years ago now. And it happened because my daughter got a diagnosis of autism at the age of 6 and had a little boy in her class who repeatedly told her that autism was a disease. And she would obviously come home quite upset and distressed about that. And I felt the school didn't do enough about it. And so I thought, actually, it would be good if I could go to schools and educate little children about autism, because just like how my children would come home and teach me and talk to me about, you know, the benefits of not smoking and exercise and, you know, recycling. They learn so much at schools. They're little sponges. And so I thought, actually, if I did assemblies about autism, then children would grow up and be more respectful of people who were neurodiverse and had neurodisabilities. My background is, I actually have a food degree from many, many years ago. And my son was diagnosed with autism when he was 4, and it felt like the end of the world to me because I just didn't understand what autism was. And at that time, many years ago now, at that time, when you Googled autism, everything was just doom and gloom. Thankfully, one of the women I worked in the office with, she had an autistic son as well, and went to a local parent-led group called ACT, which stands for Asperger's Children and Carers Together. And that place became my lifeline, where I learned a lot about my child. I learned a lot about myself as an individual. I started to realize that my daughter was struggling with some things, and she got a diagnosis of autism when she was 6. And through that as well, learning about my son and learning about my daughter, I started to see and acknowledge the difficulties that I've had growing up, which I kind of didn't acknowledge before or masked, because a lot of girls mask the difficulties that they have when they're autistic. And so 4 years ago at, I won't say my age, but almost 40, I received a diagnosis of autism as well. And then I decided that, you know, I really wanted to understand what autism was, because autistic people are so different. And I wanted to try and advocate for my kids as much as I could. And I thought, you know, I need to not just understand the day-to-day understanding of autism, I needed to understand it on an educational and scholar level. So I went back to university, and I should have completed a master's in autism studies in July, but obviously COVID got in the way and I had to kind of put it on hold. So fingers crossed, by July this year, I would have completed my master's in autism. So I'm not just an autistic adult with autistic children, but I've also gone and learnt about autism so I consider myself to be a scholar in it as well, which I hate those kind of words. I really struggle with university. I really struggle with the language. I talk and write differently to how you have to in university to get good grades. So it's really, really hard for me, university, but I have kind of persevered in it, and I've learned a lot and become a more confident mother and autistic woman because I understand it more now. So Miss Talk was kind of created to teach children, but then when I went to university, I understood just how difficult it was for Black people to get a diagnosis, because the diagnostic tools are culturally biased. And I didn't realize that at the time. So just the interactions you have with the people who are diagnosing you, their perceptions as well, their microaggressions often lead to people getting misdiagnosed with something else, or, you know, you're not getting diagnosed at all. So that's a little bit more about me. Now, any talk I ever give, I always show this slide because it's really important for me to stress that, you know, you can see that circle for white and what that encompasses, and you're classed as white on the ONS. And then in the yellow circle, you can see you have Arab, you have mixed race people of various mixedness, you have Black, you have Asian. I mean, under Asian, you've got Indian, Bangladeshi, Chinese, you probably have Japanese as well. Under Black, you've got Caribbean, you've got African. And so there's this big circle of people who are classed as BAME or BME or person of colour. So whenever there's a talk or a session that I attend and people say, oh, we've got somebody from the BAME community, we've got a BAME representative, I always ask, what does that mean? Because as an individual, I cannot tell you what it feels like to be a Japanese autistic person. And it would be absurd for you to presume that I could. But at conferences, a person will say, we have a BAME representative to talk about autism. And for them, for the white communities, it's a tick box exercise. But for us as individuals under the BAME umbrella, you are missing the very essence of who we are as individuals. And so I think it's always important for me to show this and to show just how many different ethnicities and nationalities come under the word BAME. And then this here, which I think is a lovely quote. It says, personally, I've never referred to my ethnicity using BAME or BMA, and I don't like it when they are used to describe me. Like many ethnic minorities, I proudly refer to my specific ethnic identity. My background is Indian. And for me, my background is I originated from Jamaica. So both my parents were born there. My husband was born there as well. But I'm a born and bred Yorkshire lass. You know, I love my Yorkshire puddings, but I also love my rice and peas, which is Jamaican. And I will happily have both on my dinner plate on a Sunday. So for me, I see the benefits of being part of this community, but I need people to understand that I'm not BAME, I'm not BAMER, I'm not a person of colour, I'm a Black woman. I also show this slide because it's important for people to understand that when you look at the pictures on the top, you see a lot of white people mainly white men. And these are the people, this is the face of autism. These are the people that played important roles in creating the concept of autism. But as you can see, they're all white and they're all middle class. So actually the concept of autism is very Eurocentric, and the concept was developed on a group of white middle class boys. They kind of saw I think at the time they would call it more like an abnormality or a difference in these people, and they used them as lab rats really, and did experiments, did observations on them, and that's how the concept of autism was created. But you need to understand that a lot of the creation of that concept is still being used now. So if you're using diagnostic tools that aren't culturally relevant for communities like mine, we're going to actually miss diagnoses within those communities. So that's why I'm always lobbying for the fact that if all the people, all the scholars, all the important names and faces of autism are white, middle class, Eurocentric individuals, of course you're going to miss Black and brown autistic people who also need diagnosis and support. So I like to talk about quality of life, because it's defined as a concept that reflects a person's desired conditions of living related to 8 core dimensions of one's life, which is emotional well-being, interpersonal relationships, material well-being, personal development, physical well-being, self-determination, social inclusion and rights. And I have the right as a Black woman and as a Black autistic woman to have a good quality of life. And so do my children. So in everything I do, I'm working towards making sure that the society and the community that I live in is better for my children. So I'm trying to ensure that everybody who will ever come into contact with my children has an understanding of autism, has an understanding of them being Black and not a BAME individual, understands that girls are more likely to mask. I want people within Sheffield to understand that autism isn't what your concept of autism is. It's very nuanced. It's if you're in a room of 500 autistic people, we're all very, very different, but there are certain things that we all struggle with, and our levels and degrees of struggle is different, but nonetheless, we are all struggling. So I've doctored this picture because I think in pictures, I don't think in words, I think in pictures. And so this picture is something, again, I always show to show that as an autistic person, we're a minority, and it's a real struggle for autistic individuals. But also as Black individuals, we also are classed as a minority and we struggle. So it's a double impact. That intersection, it hits us much harder because we are Black and we are autistic. And there's a lot of infighting within the autism community because there's a belief that we're all equal and we're all struggling. But I always try to let people understand that autism is it's like a micro world. And if you think of the bigger world, we're in a time where we're having to still fight and explain to people that Black lives matter. So that's also happening within the autism communities as well.
1 minute warning, Melissa, sorry.
Thank you. It's really, really important for you to look at me and yes, people might say, oh, you're very articulate. What you're saying makes a lot of sense. But I can't stress how much work has to go into me being able to sit here and present. I can't explain how much medication I have to take to be able to function, how many times I have to read one email for it to make sense, how long it takes me to write a single email, how long it takes me to just function day to day and appear to be normal. And so I'd like people to kind of leave here understanding that the prejudices that we have towards autistic people who are maybe able to function is really affecting our community. I'd love people in positions of power to think about autistic adults more and get them into the rooms, get them to talk, get their opinions, because our opinions and our thoughts matter. Because before we were autistic adults, we were autistic children. And so we're able to feed into the work that's being done to help the autism community as a whole. But you have to be willing to help us and not be gatekeepers anymore. So that's all I have to say. Thank you.
Perfect. Thanks, Melissa. Thanks so much for your contribution today, and also for all of the great and really important work that you do. Thank you. So next up for our next speaker in our People Powered section is Catherine Hale. And Catherine leads the Chronic Illness Inclusion Project, which champions the voices of people with energy limiting experiences. I'm just going to hand over to you now, Catherine.
Thanks, Joe. Hi everybody. I did actually send a slide in. I don't know if you've got it there, or shall I bring? Oh, brilliant! Thank you so much. Yes. So just gonna change my viewing so I can see my talk. There we go. I'm Catherine Hale. I'm going to be talking mostly about sort of like statutory social care and people with chronic illness. I was a social care user myself back in the 1990s. I've had my chronic illness for over 3 decades, and when it was really acute in my 20s, I couldn't feed myself, wash myself, couldn't go to the toilet, and I had a social care package. But years later, when my condition was less severe, my needs were kind of harder to grasp because they were invisible and poorly understood because of the nature of my condition. And the social care system completely let me down as a disabled lone parent, and let down my children too. I became a disability activist and realised that my experiences as a person with chronic illness were common. In our online communities, people with different diagnoses share the same experiences of fatigue, limited energy and pain. And we also share the same experiences of social injustice and oppression. Actually, a lot of that oppression is based on disbelief and denial of our impairment and our disability. So in 2017, I founded the Chronic Illness Inclusion Project because our experiences and voices as disabled people weren't reaching decision makers. And so policies and services such as social care completely fail to meet our needs. So what do I mean by the chronic illness community? Well, 1 in 3 disabled people has impairment of stamina, breathing or fatigue, according to government data on impairment types. That means kind of different types of disability. But with chronic illness inclusion, we developed the term energy impairment rather than stamina, breathing or fatigue, because we find there's just too much negative cultural baggage around the terms of fatigue and stamina. So as you can tell from that data, many disabled people experience some element of energy impairment, but when it's the main feature and the most restricting feature of a condition, we call it energy limiting chronic illness. And you'll probably be familiar when I mention things like ME, fibromyalgia, lupus as kind of classic examples of that type of chronic illness. Now, if you ask people with energy limiting chronic illness or ELCI, what's your vision for social care reform and independent living? Actually, most people don't know what independent living is as defined by the Disabled People's Movement. And that's because most of us aren't getting any statutory care or support at all, let alone one that offers self-directed support or choice and control over our assistance, as the concept of independent living means. Of course, part of the reason for that is cuts to local authority budgets that have decimated social care funding and services for all disabled people. But there's something more going on for people like me with chronic illness, and that's what I'm going to talk to you about today. So you might be thinking at this point, isn't it just because our needs are not severe enough that we don't qualify for social care support? So I want to share research with you that will hopefully challenge that view, based on a survey I did with Action for ME in 2015. Of course, ME is just one type of ELCI, but it's an important example because according to several peer-reviewed studies, ME appears to be the most debilitating of all chronic conditions, more so than stroke, MS, or schizophrenia, for example. Now, in our survey involving over 800 people with ME, we found that 97% had needs for care and support that made them potentially eligible for a care package. And if you can see the chart I've got on my slide, lists daily living activities. And according to the Care Act, if you have difficulty with 2 or more, you may be eligible for support. So 97% of our respondents had these 2 or more difficulties, and yet only 6% had a care package. And in fact, only 16% had even had a social care assessment. So even in today's climate of austerity, this suggests an exceptionally high level of unmet need in our community. Now, of this tiny percent of people with ME who got through the barriers and got a social care package, more often than not, they were met with a service that was completely inappropriate to their needs and even damaging to their health. And I'm talking about something called reablement, or sometimes called enablement, which is a short-term package of support that aims to decrease your dependence on care and increase your independence. Now, reablement is a fine idea for people following a stroke or an injury or an operation, but it's a completely wrong-headed approach to energy-limiting chronic illness, because people in our community typically ask for support only after battling for years to remain independent. And then they find they get a care package, but it consists of being pushed to do more for themselves. And even worse, reablement means you have to do activities of, say, washing and dressing in the short time frame of a care visit with no rest in between, which for someone with severe ME can cause a relapse, because we can only do one small activity at a time and need long periods of recuperation. So our respondents said that being put through reablement was actually worse than getting no care at all. So a major factor in this neglect and this mistreatment is a misunderstanding of energy impairment. And this applies, of course, not just to ME. And it's not surprising, because when you look at the language and concepts of disability used in the care sector and in policy making generally, it's very striking that energy impairment and any description of chronic illness are missing. So I put these categories down here, which are sort of typical categories for impairment, which divide disability into mobility, mental health, sensory impairment, learning disability, autism. Those are the kind of the basic categories of impairment that you usually find. But there's nothing that captures our experience, despite the fact that, as I said, 1 in 3 disabled people has impairment of stamina or fatigue. So it's little wonder that when it comes to social care assessments and care planning, our needs are just not acknowledged. Energy impairment is different from other forms of impairment. It involves the rationing of extremely limited supplies of energy to achieve basic tasks of daily living in a way that other people completely take for granted. Tasks like washing, dressing, or preparing a meal. We may be able to do any of these given tasks, but only at the expense of being able to do another one. So what care professionals don't understand is that we may be able to perform all the basic tasks of daily living, but not on the same day, or even in the same week, or we might be bedridden for several days afterwards from the effect of performing just one of these tasks. There's also no understanding of the cognitive dysfunction involved in ELCI. So for half our survey respondents, cognitive problems meant they couldn't even navigate the bureaucracy of assessments and planning for social care. Yet they didn't qualify for independent advocacy because they didn't have a recognised cognitive impairment like dementia. There's also no understanding of the sensory intolerance and sensitivities involved in ELCI that can make care needs extremely complex and challenging. All these experiences and needs are ignored and discounted because we don't have a formal label that identifies us as a cohort of disabled people with distinct needs. Closely tied to this, there's what we call systemic disbelief. So 60% of people who've been turned down for a care package attributed this to disbelief and dismissal of their account of their needs by the person assessing them. Disbelief is also a formidable barrier when it's internalised. 2 in 5 respondents said they couldn't ask for support because they were too anxious about being judged as undeserving, faking, or otherwise not genuinely disabled. We call it systemic disbelief because it's rooted in the way medicine constructs knowledge about the body and disease, and the authority that medicine has over other areas of society and social policy. Within medicine, experiences like fatigue that can't be measured are systematically erased, or they're given labels like medically unexplained symptoms or functional somatic syndromes, or other variations on this, which are actually little more than euphemisms for old-fashioned notions of hysteria. And once labelled in this way, we're stigmatised and our credibility as witnesses of our needs is undermined, and our symptoms are put down to laziness or malingering, or what they like to call false beliefs. So this ignorance and lack of understanding of energy impairment and the systemic disbelief of our needs kind of self-reinforcing and mutually perpetuate each other. And we need to challenge both of them if we want to improve social care provision for people with energy limiting chronic illness and support people to have more meaningful and socially connected lives instead of living in the deprivation and neglect as so many are today. We need to start by identifying and counting ELCI and energy impairment in the same way we do with other impairment types. Only then can our needs be incorporated into assessment systems and planning for care. We need training for care managers and care workers so they understand the impact of our conditions and what kind of support we need to live as fully as possible. And of course, we need an immediate end to the use of reablement for all types of chronic illness. Underpinning this, we need the social care system to move away from medicalised models of disease and these kind of stigmatising constructs of psychosomatic medicine. We need to listen and give credence to the lived experience of patients and service users. But beyond statutory care services, I want to end with a broader vision for inclusive communities that I'm really excited about at the moment and want to share with you. Because a lot of people with chronic illness are disconnected from their local communities and potential networks of support because they're housebound. And with the COVID pandemic and lockdown, one unexpected but positive outcome is that society became more accessible to those of us who define ourselves as housebound, because everyone in the world practically has been housebound, so has had to find ways to meet and connect through technology like we're doing today. And suddenly we've become included and been able to participate in our communities in a way that we weren't able to before. And people with chronic illness are afraid that once lockdown restrictions end, we're going to be excluded from society once again and lose all that benefit that we've gained, ironically, during the pandemic. So with remote access technology, and I'm talking about things like Zoom, there's a real opportunity to sustain the inclusion of this invisible group, if you like, of disabled people with chronic illness, because the pandemic has shown that the technology is workable, and we need to develop ways of integrating remote access into local communities once they start meeting face to face again, so that we can be meaningfully included and take part in our communities, even for those of us who are going to remain stuck inside once the lockdown ends. And that's the end. Thank you very much.
Great, perfect. Thank you very much, Catherine, for your talk. That was great. Thank you. I'm very happy to be introducing our next speaker, Shahida Siddiq, who is going to be talking about the potential of citizen action. So I'm going to hand over to you now, Shahida.
Hi everyone, thank you. My name's Shahida Siddiq. I'm the Chief Exec of an organisation called FaithStar. How would I describe it? It's something that I'm really passionate about. I would describe us as having the values and ethos of the VCF sector, the partnerships of the public sector, and the drive of the private sector. If it's one thing I've learned throughout my experiences, I've lived Apologies, I don't know how that happened. I'm so sorry. I'll start again after talking to myself. Good afternoon, everyone. I'm Shahida. I'm the Chief Exec of FaithStar. We're an organisation that's been around for nearly a decade, but we're very passionate about racial and social justice, equalities, human rights and inclusion. And right now, the health and social care agenda is really, really important to those two areas of work, racial and social justice. And civic action informing that work has been really, really vital. When we talk about health and social care and how we hear lived experiences of communities and how we can enable and empower that voice, civic action and the potential for civic action becomes so vital. And I say this from lived experience of sitting in, and I'm sure as many of you will have, hundreds of meetings where people in health and social care will talk about, let's do some co-production with the service users, or let's go out and do a consultation with communities. But in doing so, it's with a preordained, predestined, pre-designed strategy, framework, structure, policy that, you know, they want everybody else to fit into. And the impact of that is it takes away agency, empowerment, voice, influence, creativity, innovation, solutions from the very communities that are wanting to address whatever those issues are. So I always kind of struggle with that term co-production, because I think, well, actually, what does that really mean? And when we look historically at the impact on civic action over the last 20 years, we've had a concerted effort to dismantle the structures around civic action that would enable people to have voice on whatever issue it is, be that community engagement, community empowerment, community networking, community solidarity, whatever that might be. But we've lost a lot of that in civic action. And so when a crisis situation hits, and we were hit with the pandemic, the potential for civic action really and truly came into its own. And it came into its own because, you know, we saw the emergence of mutual aid groups where people were like, I just want to help my next door neighbour, I want to do something locally. But civic action also took many different forms. Civic action could be down to somebody, you know, making the decision that today, no matter how much they're struggling and they're sat in the pit of a black hole and they can just see a tiny speck of a light up there, that they were going to fight their inner demons and get up that day. And so sometimes civic action is in the minutiae of fighting within your own head and going, I'm going to function today. But civic action is also the other extreme, where it's the bringing together of people, it's the bringing together of ideas, it's the bringing together of solutions, and it's seeing members of the community as assets, as experts in their own lived experience, as experts to share what happened to how they improved their own lived experience that could potentially positively impact on others. But because we have lost the knots that bind us, the things that tie us together as communities for very many years, that disconnect has created vacuums. And within that vacuum, civil action has taken a very different form. Because civil action without a clear purpose, civil action without a clear vision, civil action that doesn't define what it wants to change, just sits there in a vacuum, you know, and that's all that it does. And I think it's really important that when we talk about the potential for civil action, when we talk about the richness of communities, that we don't do to communities, and that we don't even do with communities, but that we actually sit right there within communities. And you know, I've sat in so many meetings and in so many spheres of influence, and people have said to me, oh, what can we do, Shahida? What can we do to change things? How can we address structural inequalities? And how can we address, you know, hearing some of those minority voices that we don't normally hear? And I simply say to people, get out from behind your desk and walk into those communities and just be present, because that will inform you. And one of the methodologies that we created at Faith Star, which we use in a whole range of our work, is a methodology called Listen, Learn and Act. And what we particularly say to people who are predominantly white people, I will say, so anybody who's not a person of colour or black, we will say, we need you to listen, learn and act. And what that means is, if you're not a person of colour, just shut up and listen. Listen and hear what we've got to say, and let us share our lived experiences. And that principle applies to any community out there that is facing any kind of social injustice, be it disability, debilitating long-term health conditions, mental health, whatever it might be. Listen, and then learn about what we're telling you. Learn about where we're saying to you that there are problems in the system. Learn where we are saying to you there are gaps in the system, or this isn't right, this isn't working. And then act on it. And the act bit is really important. This is where civil action comes into its own. And I've had this debate many a time where people will say, well, we need to go out and protest outside the town hall. And my response has been, yes, a protest is really good, and getting a following on social media is really fantastic. But unless you know that that is going to impact the commissioners or the criteria writers for the bid that they want at the council, or whether you know that that is going to influence the people in the NHS or the CCG or whatever other provision within health and social care, unless you know the people, those decision makers that need to be impacted, what point is there for you standing outside the town hall? Because standing outside the town hall is one thing, getting into the system within the town hall and influencing change there, that to me is civil action as well. And there's nothing wrong with protesting, it has its place. But civil action is more, and I get really frustrated. I hear people, they talk about civil action as if there's this, movement, and it's not just a movement. It's in the everyday, it's in the mundane, it's in the fighting at so many different spheres, at so many different levels. And it's about re-education and retraining and reconnecting, and it's about rebuilding relationships, and it's about reconnecting people where they can have a voice and they can have an influence. So civil action takes so many different forms, and it takes so many different skill set, and we have those skill set in communities. We have those community connectors. They're the one person that everybody goes to when they've got an issue, and it doesn't matter if the public sector or the kind of establishment, central government, whatever the health and social care structures and sectors are above her, all of it, yeah, that's there, that's great. But actually, if that's disconnected from communities and people and their lived experiences, and if all we're defined as is service users and clients and patients and people that we just need to kind of fit into neat little boxes, we never get truly meaningful change. And so to me, we need to celebrate the potential for civil action, because we need to tap into that spirit. We need to tap into that spirit that says, together, and sometimes maybe even not together, we can actually do something, and we can make a change in whatever it is we want to make a change to. So for me, civil action, the power of civil action is rooted in the citizen, and it's rooted in the community, and whatever that community might be. But it's also about intersectionality, because as Melissa touched upon in her presentation, we can't just lump people together. We can't just say, well, actually, we have this problem over here, but actually we're not going to hear from all these people because we don't really, we don't get it. We can't understand it. And some of our community, some members of our community are at a distinct disadvantage, and they aren't just starting at a place of inequality or racial and social injustices. That isn't the same starting point as everybody else. And so when we talk about civil and civic action, it's about how do we level up our community civil action and civic action that is rooted in racial and social equity, that is rooted in environmental and health equity, that says, actually, we know when we come together around this particular civil action that some of us in the room have got it worse. And that's not to take away from anybody else, but that if we're genuinely going to inspire change, if we're genuinely going to address some of these issues, it starts with, first of all, looking at ourselves and looking at our comrades and our colleagues and saying, well, actually, I need to be at the same point in the journey that they are. Do we have a shared vision? Do we have a shared understanding of what it is that we're trying to emulate in this civil action? And is whatever action it's taken, have we got the right actors in the room? Because sometimes civic action doesn't always go the way we want it to go, Oh, interesting. Yeah, somebody just put on, where does class put into it? And that's an interesting one. Class and race and intersectionality of class.
Wind up if that's okay.
Yeah. So I'll leave it there, but just to say that for me, the potential of civic action to change health and social care is about making it person-centred, community-centred, and rooted in people's lived experience.
Great, perfect, Shahida. Sorry I had to cut you off at the end there. It was a really fascinating talk. Apologies for having to cut everyone short today. Some great comments as well, so there might be a few questions in there you might want to look at responding to as well. Thank you very much, Shahida. So next up, I'm going to be handing over to Dr. Pippa Murray, who's going to be talking about family leadership in social care and talking about what families with children with disabilities really need and what really matters to them. So I'm going to hand over to you now.
Thanks, Joe. And thanks, everyone. It's really hard to follow all these amazing talks, but I'm going to give it my best go. So I know from first-hand experience as a parent and grandparent now, how it feels to be responsible for the happiness and well-being of a child who, through no fault of their own, experiences exclusion on a physical, social and cultural basis, and how we as parents experience that same exclusion because of our relationship with and positive attachment to our children, and how the systems of support set up by the state to help us end up disempowering us. However, luckily for me, I had an amazing teacher. My son, who had no formal method of communication, opened up a whole new world to me. He led me to listen to him. He led me to network with inspirational disabled people from around the world who explained to me that impairments of one sort or another will always exist, but that social structures and cultural beliefs can be changed, and that the inclusion of everyone is the only way that we can all fully realise our common humanity. As soon as I understood that, and it did take me a few years, but I did understand it, I was able to start campaigning for change, both within my own family and collectively with other families. And in my early years as a parent, I came together with other parents in Sheffield, and we began to flex our individual and collective leadership. I remember so well the moment it dawned on me that we, as a group of parents, could use our agency and become part of the solution. In 1994, we organised a conference on inclusion in Sheffield. It was the first collective campaigning that we as a group of parents had done. And we felt we didn't know what we were doing, but we managed to get over 100 people to come to this conference. It was on a Saturday and there were about 20 or so families there and 80 practitioners in the city. And they stayed for the whole day. And in the middle of that day, amongst amazing speakers, about 6 of us parents who had organised the day stood up, and we had little bits of paper. It was before the days of computer and PowerPoints. We had scrappy little bits of paper. And we stood up and told our stories, and we put our dreams for our children on the line. We did not want to accept the status quo. We wanted our children to be included and accepted exactly as they were. We wanted this for our own children and for all children. And although my son is sadly no longer with us, I have the same dream now as I did all those years ago. It shocks me when we were young parents doing that conference, we hoped that in 10 years' time, things would be different. It's more than 10 years, 30 years, and things are still very, very hard. I remember the moment when we nervous parents told our stories, and as we spoke our truth, the silence in the room was charged with a potent electricity. And although we were nervous, some of us were in tears, we were exhilarated and felt strong because for the first time we were owning our power. And the discussions that we had that day were ongoing. And after my son died, I've been working with many young disabled people and parents. And through our discussions, we concluded what we'd started that day, that we need much more than isolated pots of money or the odd access to a club in order to give our children rich and fulfilling lives. We understood that our resilience was our most precious resource. And through developing that, we were able to create and nurture well-being and inner spirit in order that we have the strength to deal with the knocks that life throws us. We began to understand that the support offered by the state, on the most part, serves to diminish our trust in ourselves and our children and to deplete our resilience. Last night, I was at a workshop with parents. We were thinking about emergency planning. It was of parents of disabled children and adults of all ages. And it struck me how little things have changed, and that this sense of having our resilience depleted by the so-called support we're offered is still there. And one of the parents last night, and I'm going to read her exact words, said, "I've thought about coming out of the social care system as it is causing so much stress, and having them involved is taking away from the positive way of life we are trying to achieve. I worry that they will put all the other things they want to put in over the things my daughter wants and needs." And so over the years, with the help of giants such as Simon Duffy and John O'Brien, parents and families, what Simon and John did were to help us develop this model of real wealth, which is supporting our dreams, our self-belief, and our struggle for equality and justice. And we learned that this model of real wealth can be used individually and collectively, and it can be applied in many different contexts. In the context of disabled children and their families, the model of real wealth supports families to build solutions around their strengths in order to nurture their resilience and take control of their lives. The model of real wealth focuses our attention on 4 key areas needed to create a virtuous circle of resilience. We've got relationships. Family leadership can thrive when parents trust their instinctive love for their child and build confidence in their parenting ability. Sadly, the disabling world we live in, we cannot take for granted that instinctive love for our children. We have to fight for it. Community. We can only thrive as families if we're connected to, valued by, and have a sense of belonging in our local communities. As we've all discovered over the past year, compulsory isolation has a negative impact on our mental health and well-being. Autonomy is essential if we are to feel in control of our lives. This means that families have to be in control of the support they receive. When support from the state is based on legislation, such as children in need legislation, that mistrusts our ability to parent and is subject to draconian conditions imposed by local authorities, it diminishes resilience and agency. And finally, it's the gifts and strengths of disabled children and their parents that need to be acknowledged and valued if we are to shape the world differently. And in these days, all those years ago and now, I've tried so many different ways to change things, but my work is now not so much about helping systems to change, but more to help children and parents believe in themselves and understand that their contribution can have a positive impact on the world.
Brilliant. Thank you so much, Pippa, for a really moving talk there. Thank you again for your words and your experience. moving on, we have one more speaker as part of this section. So I'm very happy to introduce Claire Hyde, who's going to be talking about breaking the cycle of careless care. And Claire was one of the critical pioneers in the groundbreaking Women's Centre, and she's led on national work on how to best to support women and families in the care system. So I'm just going to hand over to you.
Thanks, Joe. Natalie, are you all right to show the PowerPoint? Thank you. Thanks very much. So, what I wanted to talk to you about today was, well, I've called my presentation Lives Mapped Out because for some children in our communities, this is exactly what seems to happen. Their lives are mapped out, but it's not in a positive way. But slide number 2, please, Natalie. So who am I talking about today? I want to talk to you about a small number of girls who share similar life experiences, including physical and sexual abuse and neglect and living with domestic abuse, and who end up being taken into care. And I want to specifically focus on what happens to some of those girls when they become mothers. Next slide, please. These girls experience trauma and abuse and eventually come into the care system. They form connections with violent males, often in quick succession, and they get pregnant when they're very young. In some cases, when they're still looked after children themselves, so at the age of 14, 15, 16. Then their own children become the subjects of child protection arrangements, usually because of neglect and the threat posed by violent males, and the children may be removed from their care. Or, even worse, the children become subjects of serious case reviews because they've either been seriously harmed or have died. And in my role as a serious case reviewer over the past 10 years, I noticed that this was a definite pattern for some girls and their own children. So I started to do some thinking and some research. Next slide, please. And this is what I found. This first statistic is horrific. It backs up what my own observations have been. So the child of a looked after child is 66 times more likely to be taken into care than the child of a non-looked after mother. The second point was based on my own observations in carrying out serious case reviews, that the children of looked after children are overrepresented in serious case reviews. This was verified after we carried out a freedom of information exercise in 2019. I just thought, how can this be right? Why isn't everyone jumping up and down in horror at this? And what's going wrong? But it's also interesting, very interesting, that the government don't collect data on the number of looked after children who are taken into care, or the children of looked after children, sorry, who are taken into care or who become subjects of serious case reviews. There's no follow-up for looked after children who become pregnant. I don't understand why this is the case, but there might also be a wider issue here. And it's what previous speakers have talked about, is the issue of class and gender and poverty. These girls are amongst the least empowered and visible people in our society. And what happens to them and their babies is not that interesting or important. Think back to Brian Fisher's presentation earlier this afternoon and what he said about control and power. And well, nearly every other speaker actually has spoken about control and power. Next slide, please. So currently, the government don't collect data on the number of looked after children who become pregnant or who become fathers for that matter. In fact, we don't even know where 17% of young people are when they leave care, much less whether or not they have children of their own. Next slide, please. So this data gap doesn't end there. So currently there's no data collected about multi-generational care involvement either by the government. Wouldn't it make sense to at least understand the scale of the issue if we're going to tackle it? So by intergenerational cycle of local authority care, I mean when one family have more than 3 generations in some cases coming into the care system. And this relatively small number of families experience disproportionate disadvantage with significant numbers of children, if you think about it, over 3 generations in some cases, coming into the care system. And these families are well known to multiple agencies in their communities, and there's a tolerance almost that this is just how things are for this family. Next slide, please, Natalie. I wanted to tell you about one example really of multi-generational trauma. This is Ruth's story. And the similarities between the histories of the mother, Ruth, and her own mother really struck me. They shared experiences of loss and neglect and abuse and sexual exploitation in Ruth's case, becoming a looked after child, early motherhood, and relationships with abusive and very, very dangerous men. So Ruth's mother was herself a looked after child, and she was so afraid of her dad that she'd wet herself when he came home. Ruth was taken into care at 13, and she was described as promiscuous at that age, when in fact she was being sexually exploited. So she had her first child at 16 to a 33-year-old and went on to have more children. And then her children were removed following the death of her youngest child. And she was at that time in a relationship with a known very violent man. And all children were removed, who became the 3rd generation of Ruth's family to be taken into care. I just think, what are your feelings about Ruth and her mum? And what about the children who were removed, the 4 of them? What do we think will happen when they have their own children? Will they be able to breeze through parenthood after all the trauma and abuse they experienced and witnessed? But what also struck me about Ruth's case was just how demonized she became. At what point did she become bad and dangerous? Was it when she was 8 or 10 or 13? Because this is who Ruth is, and this is who the baby was who was killed. Can we have the next slide, please, Natalie? Thank you. So just think back to Ruth's story. She was afraid for most of her childhood. And just think about how demonized when she was when her baby was killed. And she failed to protect him from her new violent partner. And what strikes me about Tracy Connolly, which is Baby P's mum, Ruth, in other words, is how demonized she still is. And just how many of us know her face. And the response we have to seeing her photograph will be, how could she have let that happen to her baby? But I think it's just so interesting that very, very few people will know the name of or remember the face of the man who killed baby Peter. Why is that? We demonized her, but he could pass us in the street and we wouldn't recognize him. He was called Stephen Barker, by the way, and his own childhood was pretty horrific. Thank you. Next slide, please. So that's just one example, horrific example of intergenerational trauma and abuse, but there are plenty more. We talk about intergenerational damage all the time. It's transmitted from one generation to the next, right? We all know families where they just seem to be trouble and have trouble. But this is mirrored by intergenerational system damage. If we've got 3 generations of the same family becoming looked after, then how many professionals have worked with those families over those 3 generations? Hundreds. And how many will have worked with both mother and her own children as they become adults and parents? Certainly, I've spoken to practitioners who remember both mother and daughter when they were looked after children. So what does that say about our response, our practice, and how ineffective it is? How can we not question what we're doing? How can we not question whether in fact we're making a difference or actually making things worse? Next slide, please. So what can we do? Well, it can't just be one thing. It has to be a multitude of things that we do consciously. But at the core of what we do must be the fact that girls who become pregnant at 14, 15, 16, whilst they are still looked after children or as care leavers, are still children themselves. And they have a right to support and treatment which takes that into account in a positive rather than a punitive way. And that means we have to address and acknowledge the impact of childhood trauma, especially the impact on how we become parents. And from the moment they become pregnant, the perception of the girls changes. There'll be a pre-birth assessment of their ability to parent their child. That doesn't happen for non-looked after children. Decisions will be made about their child's future, and at the very best, support will be put in place for this 15 or 16-year-old girl to live independently with her child. But the clock is ticking, and it's waiting for the disaster to happen, and happen it will, because we don't treat that girl as if she was our own child. We don't provide 24-hour, 7-day-a-week loving support and show her gently, leading by example, what good, safe parenting looks and feels like. So what chance are we giving her? We set her up to fail, we compound the damage and the trauma she's already experienced, and we remove her child. And in some cases, each time she gets pregnant, we remove each child, and we don't get it right. So we do need a radical rethink about this cohort of young girls. And we have as much to learn from the girls who do go on to become happy and secure mothers as we do from the small but very important number of girls who do not. So thank you very much for listening. That's the end of my depressing, I'm sure, PowerPoint. Thank you. And was I within time, Joe?
A tiny bit over, but I won't quibble. That's all right.
Thank you. Thanks for letting me ramble on.
Thank you, Claire. Thank you again for your contribution and your talk today. Thank you very much.
Thank you.
I'm just going to put up our next poll, and I think we'll have just a few minutes brief comfort break before we enter into our next section. So we'll be back in about 3 or 4 minutes time, and I'll just leave the poll up running in the meantime. So thank you for everyone filling in that poll. You can see almost consensus approach there, that people saying the kind of social care we need is that social care should be much more focused on supporting people, families, and neighbours. Great. Okay, so we are now heading into session 3, which is all about rights-based approaches to social care. So I'm now very happy to introduce our first speaker and chair for this section, which is Caroline Wall, who is a disabled woman from Sheffield and co-founder of Sheffield Cycling for All. So I'm just going to hand over to you now. If you could turn on your video and microphone, that would be great. Perfect.
Right. Am I here?
I can hear you, but I can't see you. Can you turn your video
hang on.
There we go. Perfect.
Oh. Hey everyone, I'm Caroline. I'll try and be positive and kind of lift us up a bit, because it's all been very real and a bit painful to hear. So I'll try and tell you some good stuff that's happened to me since I've been receiving a direct payment, and since I've become more community aware, really, more community supported, I think, is I started receiving a direct payment 12 years ago, when no, 14 years ago, when I became a single mum of a 6-year-old and a 2-year-old, and because my partner had left, and I had to get my kids from home to school and nursery. So I decided to, and I got supported by social care and received a direct payment, which was fantastic at the time, because Sheffield had decided to launch upon this personal budgeting, self-directed support. So I could choose who supported me. They didn't need to be DBS check, because I approved. I mean, like, my neighbour took my little girl to school and I bought her a box of chocolates or a tin of biscuits a week, which didn't cost very much, even though it would have cost like £50 a day to have somebody take my kids to school and nursery, at least. So, and I could save what I didn't use of that part of my budget for something else that I might need, as long as it fitted in with my support plan and met one of my needs. So that was all great. And I decided that I wanted to swap my electric mobility scooter for a tricycle. So I got in touch with lots of people in order to get some help doing this, because I've got no idea. I knew nobody who cycled, and I just thought, well, it kind of ticks a few boxes, and I can save the money that I'm having to spend on an electric mobility scooter. So, you know, I'd be using my own power type of thing, and so I got in touch with a cycling development officer and the health champions, who were fantastic. They funded me going to Hillsborough Park, Sheffield, which was where, in partnership with a cycling development officer, I started Cycling for All, after we went round the whole country looking for a suitable trike tricycle for me to ride to get my kids to school and nursery. And we went to London and various places, and I actually got one paid for by Cycling UK. They bought my first tricycle, and that's what I used to get to school and nursery. And we then opened up a cycling project at Hillsborough Park, Sheffield, where we had an assortment of tricycles and hand cycles and even a wheelchair, Velo Plus it's called, to carry people in wheelchairs so they could feel the wind in the hair, and it still is a whole social thing, you know. People, the cycling is just kind of like the bones of the community. The flesh is the people. It's the like having a cup of coffee and having a chat and finding out how somebody's mum is, you know, and that sort of thing. And it's all very community based. Everyone looks out for each other. And I started that. No, I started my cycling journey through that and through Cycle for Health, which was me cycling a tricycle with a lot of people on two-wheeler bikes, you know, like racing bike kind of guys who would all see me struggling on a tricycle, and they'd all think, if Caroline can be happy struggling and still smiling, well then I should be. And so they became a big network, a big support to me. You know, everybody, I became friends with all the cycle trainers and such like. And I could use that, I could take the money that I was saving on not paying for personal assistance to take my kids to school to fund my taxis to get me to Hillsborough Park and to get me to learn about it. It's the equivalent of cycling proficiency. I had to learn how to cycle on the road and things like that in my little tricycle. So I learned how to do that, and as I said, the health champions became involved, and I did a lot of public speaking and a lot of promotional work. And I was nominated to carry the Olympic torch by Nigel West. Some of you might have heard of him. And I got chosen to carry the Olympic torch. I carried it through Conisbrough. Fantastic day, best day of my life. And that led to all sorts of things. It's led to me working with adult social care to develop self-directed support and the training of social workers to deliver self-directed support, and so we co-produced all that, and we co-produced the training, and that led me to become part of Think Local Act Personal and the National Co-Production Advisory Group, which has been fantastic. It's just led me to so much.
Sorry, Carol, 1 minute left.
I've got so much to say. And COVID, in relation to COVID, I really wanted to use my budget to buy a laptop and carry on with the meetings on Zoom, but unfortunately they've gone from being like a council that lets you use your budget for creative, beneficial things to saying no, I couldn't use it for that. So it's in a bank waiting to be used for something, but not my need. That's it, I think.
Great, thank you, Caroline.
There's loads of things I could say.
No, no, sorry to cut you a bit short.
I know.
And yeah, congratulations on the Olympic torch. That sounds great. You know, that's a nice story for us. So thank you very much, Caroline. If you could turn your video off and microphone, that would be much appreciated. So now going on to our next speaker. So very pleased to have Liz Leach with us, who Liz leads an organisation called Imagineer, which is a pioneering organisation from West Yorkshire that supports people to create personalised and creative solutions in support. So just going to hand over to you now, Liz.
Hello, everyone, and thank you to Simon for inviting me along to speak at today's event. So I'm Liz, as Joe's mentioned, from Imagineer and the National Brokerage Network. And I'm wanting to share with you some of the insights and experience that we've had in providing support brokerage. So thank you very much for sharing the slides. This is an image that we use to represent support brokerage. And as I go through what I want to talk about today, I'm hoping that the image begins to resonate with you a little bit and begins to make sense. So when we look at the health and social care system that we have, when we look at it historically, it's a system that has been organised around a focus on deficit, need, labels, and the diagnosis that people have. So it's based very much on the medical model and the professional gift model. But in our experience and the people that we have got to know along the way in the work that we've done, citizens generally don't want to be excluded from society, and their lives defined by the labels that have been placed on them, and even the deficits that are perceived deficits. Even now, we do have a health and social care system that's organised in that way, and that leads to a loss of control, a loss of identity, purpose, a loss of presence, and a loss of self-worth. And in effect, that very approach builds a dependency on a system that's already in crisis and already overstretched. We all want to see and be part of vibrant and inclusive communities, but how do we achieve that? And one of the things that we quite often talk about is, how do we find the resource to make that happen? How do we fund it? How do we change that culture? But can we instead look at whether the resources are already there? The abundance of resources that are there, and just find another way of using them differently and realigning them differently. Support brokerage as a function is really built on a range of strength-based approaches that have been developed over recent years. And in the image itself, we've mentioned some of the strength-based approaches there. So person-centered planning, an approach to planning where we hear the person's voice, and it's about how they want to live, not about the services that are available to them, but what life means to them and what the essence of that life is as well. Looking at asset-based community development, where we look at connecting not on the basis of what's wrong, but on the basis of what's strong, what is there, how can people connect in a way that makes sense, in a way that has meaning. And local area coordination, and we've heard about that today, and how that brings strength to communities as well, and how funding that is there can be personalised so that it can be utilised by the person in a way that makes sense to them. So these approaches have been developing for some time and for some years. And in fact, when we say years, we actually mean decades, because support brokerage started in the late 70s, and some of these other approaches have started around about the same time. But we're 40 years on now, and our health and social care system is still struggling with the concept of relinquishing power and control and becoming a conduit for people to live a good life and to live a life that makes sense to them. Often those that access the social care system are asked to be realistic about what they can achieve, as people are expected to fall into the system's reality of sparseness as a result of the austerity that we've experienced over the last 10 years. So people are asked for their reality to become the reality of the austerity within our social care systems. And that ignores all the resources that are there for people. It expects people's lives to be underpinned by the funding that comes from the health and social care system, when we know there's much more than that. And we know as well that in recent years, the people that we work alongside and the people that we know, when they receive contact from a representative of the local authority and the local authority social work team, in a lot of instances, it does invoke a sense of anxiety and fear. And the very first question that people have in their mind is, what are they going to try and take back now? What are they going to try and cut from the support that I have in place now? And that's not the approach that we should see. That's not what people should experience. Now, it might seem that I'm speaking in very general terms, but it does represent the experience of many of the people and the families that we've worked alongside over the last 12 plus years. So it's representative of the stories and the experiences that people have. But within this, there has been real pockets and moments of inspiration where those that hold the statutory strings have radically changed their approach to do something that's right for the person, even when the protocols and the systems and the current agendas they work within do not naturally accommodate the approach. They've done it against the grain, and they've done it because it's the right thing, morally, ethically, and logically as well. So support brokerage does bring many of the solutions that we're looking for. As support brokers, we've brought that independence to help the person navigate through the complex health and social care systems to reach an outcome that's actually right for them. And I've got to say, sometimes that is not an easy task. It does rely on us being able to have some level of legal literacy, to be able to have focused negotiation skills and a detailed understanding of the processes and structures that are in place. And I do often wonder, how do people cope with this when they're doing this alone? How difficult and overwhelming this must be. Now, it sounds like all doom and gloom, doesn't it? But interestingly, it's not at all. And in our experience, there's a whole other and much bigger side to support brokerage, where there's light, warmth, possibilities, and real connection. And that is the community. That is where we find that part of support brokerage. And we find it in the wonderful way that people come together. People get creative, and people are committed to finding solutions. And that has always been a real source of inspiration and energy for what we do. Recognising how resources can be shared for common good and to reach the aspirations people hold. And when the conversations start with what a good life means for the person, and the focus is shifted to their strengths, skills, gifts, and followed up with people coming together to consider what is possible. It's then that we start an exploration of the people and places we know, where is the knowledge, where's the skills, and the sources of support that make things possible. With this big picture view, the resources from the health and social care system actually become a very small part of a much bigger horizon. We have demonstrated time and again that with a person in the driving seat of their own lives, this approach supports people to achieve a life that makes sense to them, a life that they enjoy living, where their identity matters and where they feel healthy and in control. Together, creating stronger connections in the community that are based on mutual interest and shared purpose. This leads to relationships that hold meaning and actually become enduring relationships. This approach also develops an awareness of people's rights and health in the health and social care system, so that when people do engage in the system, it is from a place of confidence and knowledge. And our motto as support brokers is that we know that we've served our purpose and our mission when we're no longer needed. And as a byproduct of this approach, people become less dependent on the statutory services as they begin to recognise the connections they have in the community. They avoid crisis situations and they make use of all the resources available to them. For us, the way that we see the future for social care is that the resources that fund health and social care needs to be placed safely in the hands of communities where that resources can be used for the greater good. There should be a complete stop to contributions for care. Access to care and support should be a universal right. So thank you for listening today. And if you'd like to know more about support brokerage, we have the website that was on the slide and also the email address if you'd like to get in touch. Thank you very much.
Great, thanks very much, Liz. Thanks for your great talk. And yes, there are bios and supporting information all on the outline document, which I believe was linked to on the ticket holder email you all should have received. So you can find out about all the organisations and all of the speakers involved today on that sheet as well. And please do remember as well, we have a hashtag of It's Our Community if you'd like to talk or share any thoughts about this event on Twitter as well. So next up, very pleased to introduce Tim Kilty, who'll be talking about adventurous social work. And Tim is a lapsed social worker who's passionate about his profession, but not so much about what it has become. I'm going to hand over to you now, Tim.
Hello, and I need to share slides because I totally missed the brief about sending one. I've got about 140. So if I can share screen, that would be great.
Yeah, Simon, if you could add Tim as a co-host, that would be great. Perfect.
Okay. So I am a seriously lapsed social worker. I did my training in the 90s when social work was actually arguing about whether it was profession or not. And I think that might be some of the difficulty. But I proudly class myself as a social worker and I've been doing it ever since. I might be dismissed as not a real social worker because I'm not registered. When I did my social work training, I left feeling like I was the people's representative to the state. But I reckon what I've seen happen is where we are now is that social workers are the state's representative to the people. But I work with social workers all the time and I don't see many bad people. So it's not some lightsaber duel between the dark side and Obi-Wan Kenobi. What I see a lot is really brilliant people being squashed. So all being squashed in this system of social care that we've created. So if we want a system of social care that liberates citizens, we need to remember that the workers in it should be liberated as well, because after all, they are citizens. So we need to be freed from the latest software upgrade, allowed to make decisions with people close to them and close to their communities. Like Melissa earlier, I think not in pictures, but in silly little cartoons. So this is my experience of working with people with in the looked after children system. So this is a family approach in social services. I'll tell you what would really help me and my family. The social worker says, that's not what we normally do. It's not possible. Somebody else says, so apart from the thing that would really help, what else can we do? And the fourth person says, I'll book you on the parenting program. That's a bit trite, but pretty true. And then I found I did this one earlier. So people don't ring social services or the social care system for interventions. So hello, is that social services? I'd like an intervention, please. Perhaps some solution-focused brief therapy, some task-centered practice, preferably of the antidepressive kind, or failing that, I'd like a set number of hours, please, and then a placement. It's all a bit mad. So Liz talked about person-centered planning. So the question in person-centered planning, what kind of life do I want to live and what would it take to get it? This question that social work traditionally asks is of what kind of services are you eligible for and which ones can I give you? And then this great question, which kind of pulled together all of my thinking about my work, was from a man called Richard Orr, who works in an organisation called Inclusion WA. And he said the question we should be asking is, how can we be most helpful in your life? And I think that is a great question. So when I do my social work, I'm guided by John O'Brien, actually, who's another name that's come up today. John O'Brien kind of sums up well, I've used that to sum up what I think really good social work is, which is listen deeply, search for capacities, seek connections, and be open to yes. And that's the thing, that's my rule book. So I've done quite a bit of work, which you can find all these reports. What I've kind of discovered is that for lots of people in the looked after care system, workers in the looked after care system, it's much easier to get your hands on £6,000 for an out of area placement than it is to get £20 cash to really help a family. That's another little cartoon, placementitis I called it. So in this work in Middlesbrough particularly, and in Scotland, what I discovered that the system often offers people is, the first one is to remove children. It often teaches families to be better. It offers time-limited solutions to fix people in situations, but you have to be referred into that, and there's a waiting list. Models, approaches, fancy dances, or programs that will have to push people through. This is what I discovered when I sat down in people's front rooms and asked them, how can we be most helpful in your life, in a very roundabout way. What families really need is somebody to listen, somebody to see the whole picture, cooker, washer, debt, poverty, etc. I remember seeing one family in Middlesbrough who were having a real struggle with their two sons who were causing complete chaos on the estate, and I must have been the 100th worker in the house over the past few years, and the mum didn't have a cooker or a washer, which is unbelievable, isn't it? It's quite difficult to look after children when you haven't got a cooker or a washer. Often families are looking for things that will knock the edges off, and understanding that life is really hard, parenting's really hard. If you add poor housing, poverty, trauma, debt into your life, see how much you drink, see how snappy you get, and see when you snap. That's kind of how I was approaching it in Middlesbrough. This is a quote from a social worker in Scotland who described his work when we're doing this work around looked after children as getting alongside children and families, believing things can be different, and putting solutions into people's own control. And I reckon that's a pretty good explanation of social work. In the work in Middlesbrough, which is where a lot of my experience came from, we definitely did that bit of search for capacities, seek connections, be open to yes. In a system of social care that's cash strapped and being savagely cut, we still spend a lot of money really badly, I would argue. So there's loads of fantastic stories in my papers. One of them that always leaps out is a young woman called Joanna, who was in residential care on the verge of being kicked out because the residential care home couldn't look after her anymore. She ended up back in her mum's. We supported her and her mum to figure out what would a really good life look like for you. How could we support you to live that life? We spent bits of money on really practical stuff like rent arrears, because they couldn't move house because they were trapped in rent arrears. We followed Joanna's gifts and interests, and we got some horse riding equipment, and we put some one-to-one support in for Joanna and her mum. And that was not about teaching them to do anything. It was kind of supporting them to get on together, supporting mum to be a parent, supporting Joanna to be a good daughter. In terms of the money, which staggered us a bit, I suppose, was I did this quick bit of maths after 10 months of working with Joanna and her mum, and the state would have spent £120,000 over those 10 months on ineffective residential care. And actually, to keep Joanna and her mum together, we spent £11,960. The transformation in Joanna was amazing. This little picture she made for one of her workers, to such and such. Thank you very much for the help you've given me and my mum. I hope you like your cakes. People who knew Joanna before that would say that she was incapable of being that nice because she was described as a monster, a big bad reputation in services. So there's loads of other examples of how we sit down, figure out with families how we answer that question of how it can be most helpful. In my day job at New Prospects, where I'm not a social worker, but I'm always a social worker, we do something called shared management. And these two stories are kind of hung around a really good social worker who rings me every 6 months and says, thank you very much for doing my social work for us, Tim. This is a man who lives quite chaotically doesn't like formal support, doesn't like support workers, doesn't particularly like me. What I have done is worked really closely with him and his neighbours and the people that he knows in the area that he lives. He very often hasn't got very much money, especially during COVID. He's, and it's another whole long story. But
1 minute.
Okay, I called in to see the local newsagent who I now know is called Graham. And Graham was saying, I haven't seen Bob for a while. He hasn't got any money. So the solution for Bob was to spend £35.80 a month to pay his papers. So Bob goes to see Graham every day, picks his papers up. Graham has a chat with him, and Graham rings me if he has any concerns. I reckon that is pretty fantastic social work. This is a quote from a man who approached a specialist autism provider who, if you can read that, it's not very specialist. They do support in 6-hour blocks and charge £25 an hour. He bought some gym equipment with his individual service fund. He says really clearly, if it wasn't for that gym equipment, I wouldn't be here. And this is my last slide. And it says, what I reckon good social work is know the people, know their people, know their patch, listen deeply, ask or try to discover how can we be most helpful in your life. And when you figure that out, you respond really quickly. I've been criticised by social workers as people saying, that's just old-fashioned social work, Tim. Like that's an insult. And my answer is, well, go away and do something. That's what the end.
Brilliant. Thank you, Tim. And some fabulous images in your presentation as well. And there's lots of nice comments as well in the comment section there. So Tim, thank you very much for your talk and presentation. Next up, very happy to come to John Burton. He's going to be talking about It's Our Care Home in Our Community, and he's had a long career in social care, working in both residential care and regulation. So John, I'd just like to hand over to you now, if you'd like to turn your video and John, your microphone's on, but you're, oh, there you are. Perfect.
I'm there. Yep.
Over to you, yeah.
Yep. Do I click start my video? Yeah. Okay. I don't know if, can you hear me? I've just been told my internet connection is unstable.
Yes, I can hear you. Yes, go for it.
Okay. Our care in our community. Our care home in our community. Many of you may think that any sort of care home is not where you or any of your friends or family would like to live, ever. I want to tell you that they can be great places to live in and very much part of their community. They can also be awful. In the UK, national regulators like the Care Quality Commission in England set the standards, and they tell us which are good and which are inadequate. I'll describe 4 different places, and I want you to think about which you might be willing to live in. So number 1, 6 men share this house. It's a family or a small community in the northeast of England. It's just a house in a street in a small town. All of these men have interests and things they need to do. They have friends, neighbours and families. People come in to help with the things they can't do for themselves. The couple who actually own the house are a bit like older parents. who keep an eye on health and happiness and make sure there's food in the fridge and pay the bills, but they're not very brilliant at the paperwork. They all have a really good main meal together each day. Each resident has his own life to live. One man does his mother's shopping and laundry. She lives nearby. The group go out together to the pub or the club where they're known and welcomed. They live a full life. They're important and valued for themselves. Home number 2, a dozen women and men living in a small care home in a West Country town with showering, getting in and out of bed. Some even need help to eat their meals. Some can forget where they are until a familiar face, a friend or a neighbour or a granddaughter, holds their hand, reassures them, and reconnects them with their surroundings. It's a warm, friendly, neighbourly place, and the people who live and work there are proud of it, and so is the town. Home number 3 looks like a castle. It's in the countryside, and some of the people who were in the first home I described might have been sent here had they previously lived in a place where they weren't understood or loved, and in despair, they began to hurt themselves, damage property, or threaten other people. In this highly specialized place, people are not understood at all. And when they resist compulsion or stand up for themselves, they're subjugated, they're restrained and sedated. This place is run for profit by an American firm, and the patients or residents are worth £200,000 a year. So they like to keep it full. And home number 4 is a large modern building, housing 120 old people. It's in a suburb of a large city. There are 150 staff. Most of the residents need a lot of help, but most don't know the area, and they don't know the staff or the other residents. Doors are locked to stop people wandering. There's a program of activities and a cinema, now used as a visitor's room. The care that people get is routine. There's no time for anything else. The staff are there to carry out their tasks, not to chat. They wear uniforms, they have scheduled breaks, and they clock in and out. This home is run by another international company, which pays almost no tax in this country, but makes fat profits for their shareholders. Now, I'm sure you've detected the ones that I would like to live in and the ones that I would hate to live in. It's obvious, isn't it? Yes, the first 2 fit the description, our home in our community. But the 3rd and 4th are simply horrible, and we should be ashamed of them. But some of you may be surprised to hear that the Care Quality Commission don't agree. Yes, the 3rd and 4th are deemed to be good because they meet the standards. Rated inadequate, the 1st has closed and the 2nd is about to close because they can't afford to bring it up to standard. But by whose standards are they judged? Not the residents and workers, not the relatives, nor the local communities. Harriet Harman, the chair of the Parliamentary Human Rights Committee, wrote this in June last year. We found that the regulator, the CQC, was no protection against abuse, and worse, lulled people into a false sense of security. She was referring to the abuse of human rights at home number 3, where people were physically and mentally bullied, and the CQC had covered up a critical report and had given the home a good rating. There's something very seriously wrong. Some might say corrupt. When the highly paid head of the regulator, the CQC, that covered up that abuse, goes on to become the even more highly paid head of the biggest care home provider in the UK, which runs homes like the one I described as number 4, exports its profit to a tax haven, pleads poverty with the government, and describes itself as the kindly care home company. And before he became the chief executive of the Care Quality Commission, this knight of the realm was the Director General of Social Care, Local Government and Care Partnerships at the Department of Health in Whitehall under a Labour government.
1 minute on, sorry.
I draw attention to David Behan's career only as a video has gone in exactly the wrong direction in the last 20 years. Centralisation, standardisation, expensive and ineffective regulation, privatisation, very poor use of dwindling resources, institutionalisation, money going to the top rather than to where it counts, precariously employed workers, poorly paid and trained, being blamed for failure, and thousands of people being shut away from their own communities. So changing this is not just a matter of finding the right funding formula. It requires those who have set up and expanded this system of social dominance and neglect to think very differently. And that starts with the politicians of all parties. Labour are just as much responsible as are the Conservatives. This is just my last bit. Strip away the cruel waste, the hopeless bureaucracy, and take back the resources that have been sold off to the highest bidder to siphon off the surplus, and we could have proper community-based care, free at the point of use for everyone for the same money. We must change this and give the power to the people who live and work together in care homes and the local communities in which the homes exist. Only then will we have what is our right, our care homes in our communities. Thank you.
Great. Thanks very much, John. Yeah, that was a great talk, really, really informative. Yes, and lots of lovely comments as well there in the comment section. Thank you very much, John. I'm very pleased to be coming to our next speaker, who is our last speaker for this third section. So could you please welcome Chris Watson, who's going to be talking about commissioning for disability rights. And Chris leads Self-Directed Futures and supports local authorities to transform their funding systems to support inclusion and disability rights. Chris, over to you.
Thanks, Joe. That's brilliant. Have you got my slide actually as well? Is that right? Just pop that up. Yeah, brilliant. Thank you very much. Yeah, and thanks everyone. Thank you very much for the invite. It's a real privilege to be able to, to be amongst you, really speaking. So, just so you know a little bit about me, it's kind of relevant to my presentation. But I started out my career as a support worker. I worked for quite a few years in loads of different settings, supporting people directly. I worked in residential care. I worked in NHS inpatient units. I've worked in home care services. I worked in supported living, supported accommodation. I've supported people in day services. I've also been a personal assistant. I've done loads of that kind of stuff right at the start of my career, and then as I moved through, I got into managing services and was obviously kind of responsible for the delivery of some of those things. I then moved out of that into for my sins into commissioning. I spent kind of 12 years working in local authority and NHS commissioning systems, and working alongside social workers and allied health professionals, really overseeing some of those services that I'd actually been working in. And when I first moved into commission, I thought to myself, this is the art of making something simple really complicated. And I still feel like that today, to be honest with you, and a lot of the conversations we have. Since that point, I kind of left local authority commissioning and set up self-directed futures, and we work around the country as part of the Centre for Welfare Reform, primarily trying to help shift personal budgets for, over to individuals to design their own support, basically. So I just wanted to share with you, so there's a few things I wanted to share today, just 3 lessons that I've learned about service-led commissioning as the first 3. So the first thing for me is not much has really changed in 20 years in terms of what's on offer to people through commission services. So I started off my career working in those settings. I can go into most local authorities in the country now and still find home care, day services, supported accommodation, residential care. And I know the mix of those has changed over time, but broadly speaking, not that much has changed in terms of those commissioned, how services have been commissioned. And I always think if you contrast that to other areas of life, for example, like a mobile phone 20 years ago to a mobile phone now, there's not been much real progress in those areas. So the other bit for me is, obviously, we've talked about some of this obviously already, support often set up around estimating the volume of support hours that people need. So in these services, people tend to get an allocation of hours, often linked to time and task stuff, but if you're lucky, occasionally to outcomes. There's a bit more of that these days, which is great. And then that gets locked into a contract for a person that could be 12 months, 24 months, whatever, in between kind of reviews. That for me just seems slightly ridiculous way of working, really, because I don't think any of us have the same day, let alone the same week, let alone the same year. So how we commission services in that way, for me, just seems really wasteful, not person-centered, and it's frankly outdated, I think, in terms of a practice. And it limits people. It limits people and their choice and control, and it limits them from doing things differently. So the third bit, I think, for me as well within this kind of model is, we talk about asset-based approaches within systems, within service land, but services are inherently done to people, not with them or by them. So, and we have kind of set up a whole ecosystem around contracting and procurement and perpetuating really what is quite a small, inflexible kind of service offer, really. And that goes around in circles. So, I've recommissioned that about 4 times in my time in local authority commissioning. The same service, slightly different, with slightly different branding, sort of slightly different outcomes, but effectively the same thing over and over again. And it continues to centralise control, obviously, with commissioners rather than with individuals. So just the other part for me is obviously just lessons. So last couple of years I've been lucky enough to be working in projects around community-led support, which is this concept of this radical idea of letting people themselves decide what they need locally, and then helping local organisations kind of match with people that have support needs and develop stuff. So the first lesson for me is when people get a budget instead of a service and they're allowed to be creative in designing their own support, they often come up with solutions that aren't just services, which is kind of radical. Most innovations, I would say, in the last few years that I've seen have been driven by people themselves and their families using direct payments. I had a look at the TLAP Rainbow, as I call it, on there, but it's the future models of community-centred support. I went on there earlier just to count up how many different types of organisation exist on that. And I came to about 36 different types of support organisations. And all of those, I would say, have organically grown from, not through commissioning, through people using their own budgets. But we've also got the Small Good Stuff Directory, which Community Catalysts have put together, which is hundreds of different types of small organisations around the country. So for me, that says innovation has happened in spite of commissioning. And I'm not saying that all commissioning is bad. I know there has been some innovative commissioning, but I think generally speaking, for me, that's a lesson. We still think 2/3 of people have a commission service nationally, roughly. But there's no reason why people can't have the same level of flexibility and creativeness as a direct payment. Local authorities and the NHS can offer individual service funds, what the NHS calls third-party budgets, which means that commission services can basically use an individual's funding more flexibly and adapt to day-to-day changes in how they want their support to be. From my perspective at the moment, not enough people are given this opportunity, but the number of areas offering these is growing fast, and it has become a right to request a third-party NHS budget for some people, which is fantastic. So, and also seeing as well for me, which is exciting, in some areas, I think commissioners are starting to see themselves, instead of being commissioners, as community shapers. And I think this is key to the future of commissioning, really. The role of commissioning should be around ensuring everybody has access to their personal budget, either through your direct payment, through an individual service fund, third party budget, whatever it is. The control should be situated with the person. And then what gets developed and what the commissioner should be doing is really helping create a menu of lots of different options and lots of different supports for people locally, and listening to local people's voices about what they want in their area, and then making that happen, and helping to support that through funding, really. So that is happening, I would say, in lots of different areas and lots of different levels. But for me, we really can accelerate it if we get more people taking up individual service funds and more local authorities offering personal budgets to people. We will accelerate this and grow this kind of plethora of options for people local to them, which is absolutely critical. So just to give you 3 practical examples as well of where I've seen this, and I'm sure some of you guys will be aware of these, but Community Catalyst work in Somerset, I think gets heralded nationally as a great practice example, absolutely brilliant. 600 what they call micro enterprises in Somerset working in local communities, providing support to people, and actually receiving a fair wage for their for the support they actually deliver, which is phenomenal. Bristol City Council doing some work with Power to Change, a program called Make It Local, which is literally about designing things locally and keeping the locus of control and power with individual citizens and local community organisations. And they're trying to develop, help broaden the spectrum of things that are on offer from the voluntary community social enterprise sector, using personal budgets really as a driver for that, which is fantastic. And obviously got to say Essex Council, we've been doing a bit of work with them, working with a range of different organisations. They're working towards basically a universal individual service funds offer, which is fantastic. They're doing it on a place basis at the moment, so people within a certain area can access an individual service fund, but the plan is then for that to become a universal offer in the next year or so across the whole of Essex, which would be fantastic as well. So, and they're probably the 3 main areas for me that stand out at the moment in terms of progressive commissioning stuff that I've been involved in. So yeah, and that's it. Sorry, that was a whistle stop tour. I was worried about going over. I normally go over my allocation of time, so that's me basically.
Great, thank you very much, Chris. No, it's really useful, really informative. Thank you again very much for your talk. Yeah, if you could turn your video and microphone off, that would be much appreciated. Great, so we're going to run another poll, I believe. Yeah. And we'll have a 5-minute break, I think, 5-minute comfort break before we come back with our 4th session. So the poll there, does the social care system respect human rights? Hi everyone, welcome back. Thank you all for voting in the poll. I'll just share the results of that before we begin our next section. So, does the social care system respect human rights? You can see the last answer getting the lion's share of responses there, saying that the social care system, no, for most people, the system doesn't recognise, protect and support rights. So I'm pleased to be able to enter into our fourth session for today, which is focusing on new economics. And our first speaker, pleased to introduce, is Catherine Littlewood, who will be talking about disability perspectives. And Catherine is an author and disability activist who has also worked inside the social care system. And today she supports Sheffield Voices, Sheffield's self-advocacy group for people with learning difficulties. Catherine, I'm just going to hand over. So if you could turn on your camera and microphone, that would be much appreciated.
Sorry, Chris, I'm just having some problems here. So, hi, I'm Catherine Littlewood. I work for Disability Sheffield, and I also manage Sheffield Voices Learning Disability Project. It was really difficult to kind of pick a subject to talk today to you about, because there's so many subjects revolving at the moment around people with disability, particularly the discrimination that people with disabilities have experienced down in COVID. I do have a mental health problem and I'm physically disabled as well. And as Joe rightly said, I'm the author of a book, Cultivating Mad Cow. And I spent the weekend this week having a lovely time with people with disabilities, connecting them on our Valentine's chat through Zoom, making connections and supporting people to feel more wanted and less isolated. And I decided to talk to you today about a situation that actually threw me into a bit of a mental health problem again yesterday after being stable for many years. I took a phone call from my daughter, who's given me permission to talk about this situation today. And she was really upset and she explained that social services had got involved and a new social worker was around. My grandson's got autism, he's 14 years old, and he's called Jack for the purposes of this meeting. And Jack is quite a complex little boy. He's been out of school for 2 years. In fact, he's had 5 schools in all his school life. He's been pushed out of education. He's been put into an inappropriate education facility that wasn't in any way, shape or form equipped to meet his needs. Then he's been shoved into another facility that he couldn't cope with, and eventually had to come out of school. And he was out of school for a whole year until he expressed that he wanted to go back into school. Now, having Jack at home is really complicated. He's violent, he swears a lot, his mum's only young, and she copes with being hit and spit at and bitten every single day of the year. She has her house smashed to bits, and it's really difficult. And consequently, she's quite depressed. And in the past, she's drunk alcohol quite a bit as well to be able to cope and keep Jack living with her. So yesterday I got this phone call and I was really upset because I believe that we've been doing everything we possibly can as a family to keep Jack safe and out of care. And I rang the social worker. Now, bearing in mind, only 3 weeks ago, the entire roof of my daughter's house fell through and the council refused to fix it because they didn't see it as being an emergency. So I spoke to the social care manager, who tells me that they actually want to try and understand why Jack won't go to school, and that he feels that he needs to go into child protection because Faye, his mom, isn't doing enough to get Jack back to school. Okay, so I asked him if he'd ever tried to get a child of 14 with autism who's very violent into a school bus to get him to school. And he said, well, he'd like to try. So we've got the council roof that's still falling through. My daughter's incredibly depressed. We've been in this revolving door of services for the last 14 years, which the cost is quite unmeasurable and nothing actually ever changes. There's not been one bit of intervention that's actually helped my family. There's been no overall plan of trying to support my family. And this has been at best containment and at the worst an abuse of power. They've come and they've gone. And over the last 14 years, we've had 22 different social workers. My grandson's had 10 PAs and none of them are still around. No one spends any time really getting to grips and understanding what the problem is. The social care seem to jump into action to initiate child protection when they really don't know how to handle anything else. They don't seem to have any other mechanism at their hand for supporting parents. Nothing ever changes. So I asked the manager yesterday, so if you go to child protection, through child protection procedures, what is that going to change? What are you going to give? And he said, well, we'll get more support. So I said, well, why don't you just give us more support? Why don't you give the family more support now? And he said, well, we have to go through child protection in order to access and unlock that support. So 3 years ago, we made a CAMS referral again. They refused to see my grandson. That's been going on now for 3 years, refusing to come out to the house. My grandson set fire to the house 4 times. Social services think that there is something really badly, seriously wrong with my grandson because he's communicating in this way that he's a very unhappy child. So let's talk about cost. Talking about cost is quite a slippery concept. So a family that's got really complex disability needs probably costs this government round about £250,000 that's spent on families, but not one single penny of that money goes to that child or that family. The cost it seems to be this ridiculous gyroscope that continues to spin around families like ours, where nothing ever changes, nothing moves on, but yet the social workers still get paid, despite how incapable and how irresponsible and inappropriate they are. So, number one lie, we're going to get more support for you. How come that we are stuck in this situation 14 years later? with another person telling us that they're going to give us more support. I find it quite discriminative. You know, I was a social worker. In fact, I'm quite ashamed to be associated with the entire profession, because it's not just my family. I've actually never seen anybody, any family or any person I work with ever have anything good to say about this system. And we looked at a book when I was a social worker called Beyond Blame, looking at how women, how single parents get blamed for things. And I think what is happening at the moment in my family is discrimination. Nobody's understanding this. Nobody's wanting to give time to properly listen. They know best. Of course they know best. There's no building of relationships. And when I question the fact that this is really bad practice, and the fact that after my daughter's been honest with them about her depression, they've instigated child protection procedures, and how on earth is that a good way to build a relationship with anybody? The system is set up and designed not for the people that it supports. It's set up for the people that actually work in it. You know, and these people continually coming out into families like ours just compound the situation. They penalise and they compound the stresses that we're already dealing with. I'm sitting on 18 complaints that I've made since my little grandson was a baby to this department, Sheffield Social Care. And yet nothing has changed, nothing. He sits in his bedroom, suicidal and depressed. And while his mom is trying to cope and being told that she's not a very good parent, he's been abused by this system. We've been abused by this system. Jack has been blamed at school for not fitting in. And, you know, Ella's been blamed as a parent for not being able to care for him. You know, when we talk about people with learning disabilities, 80% of all resources are spent with social workers trying to keep people out of the system. 1 in 6 people that end with a learning disability enter care proceedings, and 75% of those families have their children removed from them. The threshold is so high for parents with learning disabilities and people that are caring for children. We have few places to turn to. And I want to say, why don't we just get rid of social care and have advocates? It's not about gatekeeping. This is our right to have a service. I just want to tell you that my daughter last night sent me a text to say she wanted to go and get a bottle of gin because she felt so distressed. I went out and got a piece of cake. I think social services owe us money for 10,000 cups of tea that we've provided over the past few years. Thank you.
Thank you, Catherine, for your talk, and thank you for speaking so passionately and sharing your personal experiences with us. It's much appreciated. Thank you, Catherine. There's lots of comments as well there in the chat as well from lots of people who really enjoyed and resonated your talk. So thank you again, Catherine. If you could turn off your camera and microphone, that'd be much appreciated. Thank you. So next up, we're going to hear from Ruth Milsom, who's going to be talking about our hopes for Sheffield. And Ruth is the Labour candidate for Crooks and Crosspool in Sheffield. She's a music teacher, secretary to the Socialist Health Association, the Yorkshire branch, and Sheffield Save Our NHS. Ruth's going to be summarising the key messages from the event and sharing her vision for a distinctly Sheffield approach to social care. Ruth, over to you.
Thank you, Joe. I hope I can do this justice. I've been madly scribbling notes as I've gone along, and I've cobbled together some slides. So this has been a bit live throughout the event, obviously with trying to present something of a summary. So I'll just share my screen and hopefully that will come up. Hopefully that's there for people. I'm going to try and present some of the key insights that we've heard today. We've heard from lots of people who have demonstrated some really fundamental principles, and those principles, if we can grasp them, I think could change everything for a city like Sheffield. Sadly, I feel a lot of these principles are things that the kind of governments we've had over the last decade are just never going to grasp. So I think one thing that comes through for me is that we have to look at how to remedy the deficits that come from a government strategy on a local footing. And that's hearing from everybody today has certainly given me a lot of hope about that, about the strategies that people are able to implement. And if we can achieve something more joined up across the city, whereby our council and citizens are truly working together, I think we can achieve something. I've noted down some of the key points that have come out of people's talks, illustrating what's wrong. I'm sure we're all aware really of what's wrong, but hearing some of the detail about where the system does go wrong, where people have felt let down, where they've been sure of the kind of help that could really make the difference for them but unable to access it, where people are leading projects and they have a great impact but it's not joined up with everything else. So some of these key points I hope are things that can be taken forward in a more holistic strategic view by our local authority working with people. The final point there I really want to emphasise that I feel local authorities do get trapped in this cycle of managing cut after cut after cut, and I don't envy anyone in that position of managing the budgets and deciding how resources are spent. But I think again, engaging in a wider network of citizens who really are the specialists on what's needed and often how to provide it can make the difference here. The main barriers I've perceived from what people are saying today, time is an interesting one because of course we've seen during the pandemic in the last year periods where people have been furloughed from their jobs and become suddenly time rich, and the kind of time that people are prepared at the drop of a pin really to put into helping their neighbours in a very basic way, just shopping, collecting prescriptions. We saw all that through our mutual aid networks that were created across the city really in the blink of an eye. So that resource is robbed from us by the current climate of work, and is something that we really need to look at how to reap back that precious resource of time. The other points there I'm sure are pretty obvious to people. What do we know? What people have told us today? What do we know from experience, from people running projects themselves that are really successful, from people being users of centralised services that really don't work out well for them? So I think main points to draw out there are that our citizens really are the best experts on what we need. They're the people who know what's needed. They're the people who see it and experience it themselves and hear it from their neighbours. And we have to get past this frustration that centralised services just don't cater to the actual needs of most people. I'd like also to emphasise here that societal participation must not be limited to the able-bodied. That was one of our first speakers, who said that they felt completely hindered by a disability and unable to work, and then a society project, if you like, a community project, it happened to be a protest, brought her back into circulation in a way that she couldn't have anticipated at all. We mustn't divide society into the people who can and the people who can't on the basis of disability. We all have abilities, and I think that's a massive mistake if, and it tends to come from top-down administration, that there are people who can't and they're somehow cast out of society. When citizens and communities are empowered, I want to draw on that as well. We've heard from numerous speakers today about the empowerment that's needed. It's time, it's money, it's recognition, and it's underpinning people's confidence to get going with a project and to ensure that it's sustainable. And then we start to see immediate and real measurable benefits. And as Brian pointed out near the beginning, and Brian Fisher in his talk, those benefits really are measurable. And on average, £1 spent brings back a £3 return in terms of health, well-being and reduction in spending in other sectors. What do we want for Sheffield? This is really where we're getting to the nub of it for us. So we've heard how having communication between the town hall and people is really important. That's maybe something that's become less possible through over the last decade, I would argue, through cuts, meaning that there are literally fewer staff in a town hall. There isn't the personnel to facilitate what's probably seen as a luxury, really, but we have to make it a priority, not a luxury. So I think we need to keep just politely knocking on that door and making sure that that communication channel process does get opened up and facilitated. Very interesting talking about community coordinators, because that's really a small spend for a council and a big return, as we've heard from the speakers. I won't go back over it all, but you all heard the benefits of community coordinators who have their fingers out into neighbourhoods and help to feed the ideas back into the towards the purse holders, I suppose. Citizen-led, community-located, rights-based. It's a big ask, but it's really not too far away from us. It requires a mindset change in the right places, but I do think this is perfectly achievable. And it's also something that can be encouraged from Westminster, probably not by this government, but certainly from our opposition benches. And we do have Liz Kendall with us today, who I hope is someone who will really champion these ideas from communities like Sheffield, and just keep thumping away at that tub in Westminster on our behalf. We need things to be more citizen-led, more community-located, more rights-based, not one size fits all. It just doesn't work. Nothing about us without us. Nobody's actually uttered that phrase, I think, today, but it's one that's constantly on my mind when I'm not disabled, I'm not particularly ill, I'm not a user of any statutory services, and yet I have the audacity to talk about how other people might want those services to be shaped. The most important thing for people like me is to listen to other people, and we've heard that today.
1 minute, sorry, Ruth.
Thanks. The rest of the points there, I think, things that various speakers have all agreed on. We do need investment to come back into municipal services, and I want to just reminisce about the days of youth clubs and going swimming for 10p and having free access to tennis courts and all that. And I want to add to that a modern twist, which is, why can't Sheffield be a place that provides a municipal fast broadband to every household? And somebody did indicate that would make a huge difference to people who are cut off otherwise from a lot of society. I'll whiz on. Do we have the political will? This is a takeaway for anyone of a political mind here today, and I'll include myself in that as a potential councillor in the future. I preach to myself. Do we have the political will to do these things? Are we spending public money ethically? To my mind, not. Do a screen share, take this slide away, have a think about it. We're paying money to private shareholder companies across the city for care home, for care delivered in homes. That's not right to me. We need to look at that urgently. Is every penny being spent to the direct benefit of citizens? That also needs looking at urgently. Can we become a city where every worker in the care sector is well paid? Are we going to tolerate care workers working for these private companies who are paid below or just on the living wage, and they're going to a food bank once a month? Also not good enough. We're robbing our own citizens by accepting this system, so we need to look elsewhere. That's the end of my slides. There are myriad other points I could make, but I know we're running out of time, and I know that Simon hopefully is going to pick up some of the points about money, because the big question is always, well, how are you going to pay for all that? So I guess it's over to Simon next.
Brilliant. Yeah, Thank you very much, Ruth, and you did a sterling job of summarising many talks and many hours of discussion and chat today. So thank you very much for putting that together for us. If you could, turn off your video and your microphone, that would be much appreciated. So yeah, I'm going to hand over to Simon Duffy now, who's Director of the Centre for Welfare Reform, co-founder of Citizen Network, and has, programmed and helped put together the whole conference today. So I'm looking forward to hearing Simon outline, the economics of progressive reform. So going to hand over into your capable hands now, Simon.
Thanks, Joe. So I want to give a big thank you to all the speakers today. Everybody I asked to speak did such a great job, and we were working to such a fierce time scale. So thank you so much. And we've heard from a great mixture of disability and family leaders from Sheffield, Yorkshire and beyond. And we've heard from other experts, people who've spent large chunks of their life committed to making this system better, trying to make it better. And we've heard some stuff that really touches the heart, the things that Catherine was saying, the things that Claire was saying, John's observations, which to me just are really powerful observations on the long-term failure of this system to reform itself. So I'm not going to try and summarize all of those things, but I do want to talk about the big issue that keeps getting ducked, has been ducked for decades, which is the money. In 2010, the coalition government introduced the biggest cuts in public spending we've ever seen. In 2010, the UK spent 42% of GDP on public services, not a high figure. Most Northern European countries spend much more than that. Just 10 years later, Treasury data puts us at 36%, a figure which now makes us an extreme outlier alongside other countries with no secure welfare state. This is a cut in today's terms of £133 billion. As the United Nations has repeatedly told the UK government, these cuts have particularly targeted disabled people and are in breach of the government's human rights obligations. The attacks on disabled people have come in the form of cuts to benefits, housing, and especially cuts in social care, which have been even more extreme than the general cuts in public funding. In 2010, social care spending was a little more, that's adult and children together, a little bit more than 2% of GDP. Today it is only 1%. This means that in real terms, social care spending has been halved in just 10 years. And today the adult social care system, for example, supports more than 40% fewer people than it did 10 years ago, despite our aging population. You might wonder how a system can survive this kind of radical surgery by government. But the reason why social care, the system survives, is that the costs of the cuts to social care are always exported somewhere else. Primarily, they're exported into the lives of people and families. They harm people and families. And we see the symptoms of these, as various speakers have emphasised, Brian, at the beginning of the day, in the growing death rates, in suicides, in misery, in hate crime, in family breakdown, and in institutionalisation. But you also see the impact of these cuts in costs that appear further downstream in other more expensive public services, the NHS, in schools and in prisons. So the system doesn't crash, it just becomes increasingly inefficient, increasingly dysfunctional. By failing to support someone to be an active and connected citizen, part of their neighbourhood, we end up with people in institutional placements, as John described, that can cost over £200,000 per year. The good news, the ever so slim silver lining, is that the governments of the last 10 years have demonstrated that social care funding, finding a solution for social care funding, an issue that's rolled on for 3 decades, was never a matter of complicated calculations of demography. It was never about need, growing need or otherwise. It was never about markets. It is, as Ruth emphasised, social care spending and our commitment as a society to invest properly in social care has always been a matter of political will. It's always been about morality. Do you want to do the right thing? Do you want to respect people's human rights? If an extreme right-wing government, and that is sadly the government we have, can cut social care spending in half because the government doesn't value social care staff, doesn't value disabled people or families or neighbourhoods, then a progressive government could do the opposite. It could choose to radically increase spending precisely because it does care about people and it does care about communities. In fact, a progressive government today, if it was such a thing was possible, could easily double public spending on social care without even taking us beyond the spending commitments of 2010. And as we set out in a recent report, if we did double the tiny social care budget, then we would be able to end two of the most shameful features of the current adult social care system. We would be able to get rid of charging and the vicious means testing, charges that are effectively a super tax on disabled people. Fundamentally, we need a universal social care service, not a service targeted on poor people, which, as Richard Titmuss used to say, a service for poor people becomes a poor service. Social care is a brilliant, sadly, case study of that truth. The current system is disastrous. People make themselves poor in order to qualify for it. People lose modest savings or disability benefits, and the better off are excluded from the service and so have no interest in supporting it through taxation. At the same time, we could also, again, just by going back to the 2010 commitment to 2% of GDP, we could lift the salaries of social care staff and personal assistants by about 50%. Current salaries are so low and contracts so insecure that many social care staff must rely on universal credit. Isn't it shameful that we subsidise social care salaries through our dreadful social security system? Of course, this is all very well. We are a long way from having a progressive government. In fact, the UK seems to be on course for another decade of extreme right-wing power. Opposition parties remain divided, and the electoral logic of the current system makes an outright Labour victory look almost impossible. But that doesn't mean there's nothing we can do. Parties on the left could agree to work together to develop a progressive vision for social care, perhaps something like a New Deal for communities. This is an easy win. The policy of working with the Conservatives on social care has been disastrous. It has simply left progressives becoming complicit in the destruction of social care. This must stop. Labour, Liberal Democrats, Greens, I'd say the SNP and Plaid Cymru too, can surely agree on the need for universal social care and a new approach which invests in disabled people, invests in families and invests in local communities. And this is easily affordable. And even without support from Westminster, even in our broken political system, there's still much we can do today. For example, here in Sheffield, we have no Conservative councillors. That's the kind of brilliant city Sheffield is. We don't elect Conservative councillors, but we do need Labour, Green and Liberal Democrat councillors to work together in the years ahead. We need a progressive alliance for this city. And even without new centralised funding, there are many changes we can focus on. We can work to eliminate charges now. We can work to lift frontline salaries now, because the old industrial model of social care, as so many of the speakers have pointed out, is so inefficient. Local area coordination, peer support, family leadership, gender-based support, self-managing teams, individual service funds, locally organised care and support, good social work, creative brokerage, all prevent needs, all save money, and perhaps most importantly of all invest money directly into the hands of disabled people, directly into the hands of families, and directly into local neighbourhoods. Just think about the waste we've built into our current system. Disabled people and families are unable to use their budgets creatively. This creates waste. Families break down for lack of support. This is so wasteful and damaging. People are sent out of their neighbourhoods, out of the city. This is so wasteful. There is too much wage inequality. The huge wage differences between frontline workers and managers is not only unjustified, it's incredibly wasteful. We allow profiteering and money to be sucked out of the city into the pockets of US investors. There is little or no focus on prevention, on neighbourhoods, on peer support and citizen action. We throw our people away and we throw our money after them. We can stop this now. During the COVID crisis, we've seen the willingness of local people to reach out and support each other. The emerging movement for neighbourhood democracy and the flat pack democracy movement are calling for people to become active citizens at the neighbourhood level. The UBI Lab network, formed here in Sheffield, shows how we can reform social security systems to support citizenship and to support disability rights. Sheffield is ideally positioned to lead in this work, to show that we can combine respect for disability rights and citizen empowerment with approaches that enable us to take care of each other and our local neighbourhoods. We must no longer invest in the old, industrial, congregated, segregated system. We must invest in disabled people, in families and in our neighbourhoods. This is the key to progressive social care reform. We must invest in ourselves. Thanks, Joe.
Brilliant. Thank you very much, Simon, for a really powerful and important speech there. So thank you again. As was mentioned slightly earlier, we're very lucky to have Liz Kendall with us, who has been able to join us for the last half an hour or so. Liz, for some of you might not be aware, is a Labour Shadow Minister for social care, and we've asked her to respond to some of the ideas and talks that have been summed up by Ruth and might have come up from Simon's talk there. So Liz, I'll hand over to you. If you could turn your video on and turn your phone on, that'd be much appreciated. Thank you.
Hi, I can't turn my video on. I think it's been turned off centrally somehow. Can you hear me?
Yes, I can, yes.
Ah, great. Oh, here we are. The host has asked you to start your video.
There we go.
Hi, thanks so much for inviting me today. It was been really interesting listening to Catherine, Ruth and Simon, and an awful lot of what's been said. I really agree with. Look, I think that transforming social care and empowering the people who use care, their families and the community is one of the biggest challenges facing our generation alongside climate change. And quite frankly, as a politician, if we can't secure a better deal for social care after the horrors of this pandemic and quite frankly the last 10 years, then we might as well pack up and go home. Like many people here, I have been banging the drum for a transformed system of care since, for over two decades. I remember back in 2002, one of the first books I wrote was called From Welfare to Wellbeing, The Future of Social Care, which was all about this social model of health that empowers the users of care, their families, the staff and the community to live the life they choose. And that's what I still believe in today. I mean, I don't need to tell anyone here that this pandemic has brutally exposed the fundamental flaws in the system that many of us have been campaigning on for years. That social care is not seen as equally important as the NHS, whatever any politician might claim. We saw just last week the Public Accounts Committee explicitly setting out how social care was utterly neglected until the horrific death toll in care homes started to rise, and how frontline care workers literally saw their PPE and protective equipment requisitioned by the NHS. I am all for our NHS staff having the proper PPE and testing and vaccination and all of that, but it is just not true to say that there was a protective ring around social care from the start. There's been a failure to see that social care is
inextricably linked not just to the NHS. I mean, we saw that with what happened with discharges from hospitals into care homes, but all the other issues that we've heard about today, what Catherine was talking about in terms of schools, what Simon was talking about in terms of people being forced to rely on the failing system of universal credit, a real lack of understanding essentially about what social care is, or I would argue what it should be. And I think at the heart of it is that services and support are not understood, and they are definitely undervalued. I would argue it's because the care workforce, predominantly female, many from Black and minority ethnic backgrounds, that care, work and support is seen as a woman's job and not worth paying, and about the value of people with physical and learning disabilities, and the fact that this is too often ignored by society. I think one of the, well, it's not shocking because we know it, but the fact that people with learning disabilities have been 6 times more likely to die from COVID-19, an issue many of us warned about right from the start, but again has been completely ignored. So I think that the need for reform has been exposed by this pandemic, but I think there is still a long way to go before we get there. Without doubt, we need an immediate injection, substantial injection of cash into the system. But actually what we want is a transformed system backed up with the proper funding that lasts for generations to come. And it's quite interesting that one of the health ministers in the House of Lords, Lord Bethell, argued recently, now is not the time for fundamental reform. The system has got too much on its plate. But I would argue the precise opposite. Now is precisely the time when we need to see big changes to give people hope that there is a better, fairer system in future. And I'm very struck by the vision of social care put forward by Social Care Future, which, as many of you know, is a movement of people who want to bring about major positive change by reimagining a different type of system of social care. And they say, and I think this is very powerful, we all want to live in a place we call home with the people we love, in communities where we look out for one another, doing the things that matter most to us. And that, I think, is the best summary I've heard of the system of care we want and need in future. It would be a system that worked for older and disabled people. I mean, if you think about it, I think that the pandemic has almost entrenched misconceptions about what social care is, that it's only about older people, not working age adults with disabilities. It's only about care homes and residential care, not supporting people's own homes or supported living or people who have personal assistance. So it really does have to be that system. And I think this is really linked to the debate we're seeing about how to pay for social care, where all the talk is about, a cap on care costs and how do you stop people having to sell their homes to pay for their care, which is an issue for older people, but is completely irrelevant when it comes to working age adults with disabilities. We need a system that fundamentally shifts the focus of support towards prevention and early intervention and helping people's own homes. I think we should have a principle of home first for social care in any reformed system. And as Simon, I think, will well know, all of that early help and support has been entirely stripped out of the system after a decade of cuts. And he talked about those cuts in a time when our population is aging and need is growing. And I think that scandal of people who are not getting any help and support is growing month on month. I do want to see a system that is fully joined up with the NHS, but not run by the NHS. I do not want a system of social care that is based within that medical model. I think that we want joined up services and support, because people don't see their needs, in separate departmental silos. But how do we get all of these changes? And this comes to a point, I think, that Ruth, I was really struck by this, where she said citizens are the best experts of their need. I could not agree more. The reason that we need to empower people to have greater say and control over their lives isn't just a matter of principle, although I believe it is, but because people know best what their needs are. They're the best people to join up support, because they don't see, oh, well, I have a health need over here, or a employment need over here, or a kind of community need over there. They're just one person. People are the best, the users of services and their families are the best people to shift the focus towards prevention, because, they don't want to see their needs getting worse and worse when they don't have to. And I would say they're the best people to ensure effective value for money, because the users of services hate seeing waste and inefficiency in the system. I believe that any politician, but I'm speaking for Labour now, we should be seeking to win power in order to give it away. And I don't just mean to local councils, because I think, as Catherine said, and as I see regularly in my own constituency surgeries, I have as many people complaining about how the local council is run as they are about, the government cuts and the implications and the impact that they have on people's life. It is genuinely about giving people power and control, or enabling people to take power and control over their lives. And of course, that is challenging. It's challenging to professionals, it's challenging to politicians, but the truth is it's right in principle and will get the best results. Finally, there will be talk about how we afford it. And I believe we do have to spell out how we would pay for care in future. We are not setting that out in detail at this stage of the parliamentary cycle, but I would also argue, just as Simon did, we can't afford not to do this. It's right, morally right, to give decent care and support. But also, we can't afford for people to be stuck in hospital when they don't need to be there. We can't afford for people with physical and learning disabilities to be put in long stay institutions, which cost an obscene amount of money, which we have seen can at the same time be terrible standards of care. It's not right that families, 1 in 3 family carers, has to give up work or reduce their hours because they can't get the support they need to look after the person they love. That doesn't make economic sense either. So yes, there is the moral case, but I believe there is the economic case too. And again, as I think Ruth said, we know that if you pay frontline care workers a decent wage, they spend it in their local community, and they don't have to rely on a failing social security system either. So I believe there is a moment to seize now. We have to do that, I think, but I really believe, despite everything that we've seen, we still face the battle of our lives, but together I hope that we will win.
Brilliant. Thank you, Liz, for that. Can I just ask you one follow-up question, just slightly based on a comment Simon made earlier, which was about how you would feel working with other political parties to help build this progressive vision of social care?
I mean, I've spent the last 5 years arguing that if we can more likely to get change by building cross-party support, then that's what we should do. I certainly don't believe that I have ever supported the Tory government in what they've been doing, but I've always been willing to work with others. I mean, the bottom line here is, I don't think that, the Tories don't need cross-party agreement. They've got a majority at the moment, but I do think having a system that lasts, whether there's broad-based agreement about the future, I think that would help. And I'm in the change business. If I can get change to happen earlier and quicker by working with others, that's precisely what I do.
Brilliant, great. Thanks, Liz. We're running very slightly over time, but we're going to go to Alexis who is the Director of Social Services, Alexis Chappell, and then we'll have a small brief panel discussion after that. So I'd just like to go to you, Alexis, for any responses, I think maybe from the talks that you've heard or anything that Liz has just said. I'll just ask to unmute. Should be able to turn on your, yeah, there we go.
Okay.
Yes,
hopefully everybody could hear me. So I just want to say very simply is thank you very much for the opportunity to listen in today. I was very much appreciated the work by Simon and his team to pull together the event today, and also that they reached out to me and got in touch. And I just want to say I'm absolutely committed to listening to the views and experiences of people who use and access social care services, and so that in partnership that we work together to enable people to live a healthy and fulfilled life. And I talked to Simon earlier on this week and last week about how we could do that, and I've given my commitment to meeting with Simon after this event to look at how we work together to engage the views of citizens of Sheffield within social care. So I'm absolutely delighted to be working with Simon and going forward. And so that's all I wanted to go and say today. And I just want to give my thanks to Simon for organising the event, and very much it's been a pleasure to listen in today and to listen to the views from everybody who's been on the webcam today.
Great, thank you, Alexis. Liz, I'm not sure whether you, I know you said you might have had to go very shortly, but we were wondering if Liz, Alexis and Simon might be willing to answer a couple of quick questions in the chat or respond to a few of them, if that was
I've got to go at 5, but if people also want to send questions on, you know, I'm very happy to take a look.
Okay, great, of course. Well, we've got 5 minutes, so maybe I will try and pull one in quickly. Let's have a look. Yeah. Yeah. Just trying to see if there's anything in the Q&A. Let's have another question here. Let's look.
Can I say something, Joe?
Yeah, of course, please do, yeah.
But it's slightly directed at Liz. Sorry, Liz. But I suppose I would really want the Labour Party to think about what the basis of a long-term new vision for social care is, because what we've seen for 3 decades is a drift that follow the consensus building process has failed to bring about the kind of changes that people have been talking about for the last 4 hours. It's actually seen a kind of ongoing deterioration, and we're being pulled rightward all the time. And so I suppose it is a specific, this talk and this conference was framed as a progressive vision for social care. I mean, it's rooted in Sheffield's experience of not having any Conservative councillors, but I would say if we want to build a coherent model for the future, the last people we need to be talking to are the Conservative Party now. Of course, they'll come along if you create a coherent, attractive vision that ordinary people want. But that work has to be done, I think, by the opposition parties, by civil society, and particularly by working with disabled people in the community now. But a lot of the jigsaw puzzle pieces are already there, but nobody's putting it together, and nobody's making firm commitments beyond platitudes to saying, this is the model we want, and we're going to fund it. It needs to be properly funded to work, so let's do that. It's not even a significant financial commitment.
I don't think I'm not sure I'm not advocating that somehow, you know, I haven't been building seeking to build a right-wing consensus. I believe in, and always have believed in you know, slightly policy wonk phrase, co-production of health and care systems, but also of policy, because I believe that, you know, the man, as it usually is in Whitehall, or woman, can't possibly know what's best, and that the people's lived experience, which is very challenging, as I said, is what we need to drive services and reform. You know, you are lucky in Sheffield that there aren't Conservative councillors, but if Labour wants to get into government, we have to persuade all sorts of people to vote for us. We have to rebuild their trust in us, that we care about the things that matter to them. It doesn't mean to say we aren't radical about the sort of vision we want to see in future, and I hope I've set some of that out, but we also have to convince people who haven't voted for us before so that we can get into power and put our principles into practice. And believe you me, it is frustrating not to have, you know, something all fully worked out and costed and presented, especially when you've been working on this issue for decades. But Keir Starmer has been our leader for a year. We're in the middle of a pandemic, but he has said social care is one of his top priorities for reform. And I have never seen in the first speech at party conference a Labour leader do that. There'll be many people on this conference or on this call who have different views and support different people. I want to see a radical reform of the care system, but we have to be credible in convincing people that it's possible to achieve, because that's how we'll get into government and hopefully put the ideas into practice.
Great. Thank you very much, Liz. Where you'll probably have to leave any moment, so thank you again for your contributions and for joining us. It's much appreciated. Thanks again. So Simon and Alexis, I'm wondering whether we are running to time, whether we should call it, or whether we should open up for a few questions. What do you think, Simon?
I like finishing on time. I suppose I would say I wanted to thank Alexis, who reached out to us to commit to working with us on this. So this conference had a kind of dual audience. It's got a kind of global audience for anybody interested in social care, but it is rooted in Sheffield. And Alexis is new in her job. I think we've shown that there's interest and support across Sheffield, but also lots of expertise outside Sheffield we can tap into to develop the kind of radical vision that Liz has just described. To me, that vision doesn't seem so hard. Like I think we can touch and see what's necessary, but it does require real work. And if we can evidence that by working together in Sheffield, then there's a lot we can do ourselves. And then the other things that we ultimately need, national politicians, whatever the UK turns into in the next few years, whatever a national politician is, you know, that will be all the easier, I think, if Sheffield can lead the way. The NHS was created on the back of places like Sheffield and Manchester, northern cities, demonstrating that we could actually create proper public health systems. So let's do the same for social care. Let's reinvent social care here in Sheffield. We'll be publishing all of the films. We'll be creating a written report on the basis of all of the work that's been done today, which we'll offer to Alexis, but Alexis has kindly offered to work with us in workshops and events after today. So we'll take her up on that. We will put an invite to everybody who's been involved, all the disability leaders who've been involved in the design of this event, to get involved in that process. So I look forward to working with her and everybody else on getting some real stuff done.
Great, thank you, Simon. There is a quick poll up there if anyone wants to quickly respond to it, but that feels like a really natural point to end today's half-day conference. Sorry we didn't get through some of those questions that you just put into the Q&A, and just a sincere thank you, I guess from all of us at Opus and at the Centre for Welfare Reform and Festive Debate, so all the contributors, all the speakers, and everyone for listening and contributing. It's been a great afternoon. So that's it from us. Thanks very much.
Thanks, everyone.
Cheers.
Joe, do we have all the data from these? Have they all been kept? All the data from the different events? They're all. I don't know how this works. Is that all recorded somewhere?
Yes, we have all the polling information. Yes, that's all good. Yeah.
All right.
We're still on, by the way. So I'll just.
No, I don't know how to.
That's all right.
I'm not going to say anything inappropriate anyway. What would I say?
Well, now's your chance. I'll stop it now, shall I?